Hello, is this working? Yes. Please turn on air condition, please. It's too hot over here. Air condition. Yes, please.
Bismillahirrahmanirrahim. Good morning. We will start the second day and the first session of Saph 2022. This session, we will start with the first talk from our co-chairman, Dr. Ragda Arif. Dr. Ragda is a consultant pulmonologist and pulmonary hypertension. And she's an assistant professor at King Abdulaziz University Hospital, Jeddah. She will be talking about Group 3 pulmonary hypertension, clinical burden and treatment update. Dr. Ragda, the podium is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. It's my great pleasure to be here today and to be the first speaker. So my task for the next 20 minutes to speak about Group 3 PH, the clinical burden of the disease and the treatment updates. Is there an echo to my sound or just me? Good. Okay. So when I talk about PH in chronic Group 3 PH, I'm talking about chronic lung disease and hypoxia-related pulmonary hypertension. So more commonly, we're talking about pulmonary hypertension and interstitial lung disease, an entity of combined pulmonary fibrosis and emphysema, because they have worsening gas exchange and high risk of developing pulmonary hypertension. Pulmonary hypertension related to COPD, and pulmonary hypertension related to sleep-breathing disorder, and specifically sleep apnea, and more commonly obesity, hypoventilation syndrome. So here you can see the updated clinical classification of Group 3 PH, and it was updated to underlying causes of obstructive, restrictive, other lung disease with mixed abnormalities, hypoxia without lung disease, and developmental lung disease. The updated 6-word symposium for pulmonary hypertension definition of Group 3 PH. So CLD is basically for chronic lung disease, and you can have patients with CLD without presence of pulmonary hypertension, and that defines that they have cath criteria of mean pressure less than 20, or they can have a little bit of high pressure, more than 21, but still have a low BVR. Patients with chronic lung disease with mild pulmonary hypertension, these are the vast majority of our patients with Group 3. They have mean pulmonary artery pressure between 21 and 24, and the BVR more than equal than 3. And this is the group with severe PH, which is not very common in patients with chronic lung disease. And it used to be called after proportion pulmonary hypertension to the underlying chronic lung disease. So they have the definition of the mean pulmonary artery pressure more than 35 or equal to 35, or more than equal to 25 with a cardiac index less than 2. So why it's important to talk about chronic lung disease related to associated pulmonary hypertension? And the reason is because it's invariably associated with reduced functional ability, impaired quality of life, greater oxygen requirement, and increased risk of mortality. Again, the etiology of chronic lung disease related to pulmonary hypertension is very complex and multifactorial. And again, very mild pulmonary hypertension is common to see in patients with chronic lung diseases. However, they usually not associated with significant RV dysfunction. So if you have someone with the chronic lung disease and you have mild lung disease, however, you have moderate to severe pulmonary hypertension and significant RV dysfunction, so please go and look for other potential causes. So look for signs of left heart disease, look for signs of CTEPH, or look for signs of pulmonary arterial hypertension as in Group 1 concomitant with Group 3 pulmonary hypertension. One important key point as well, if you have somebody comes in with acute exacerbation of COPD, acute exacerbation of underlying interstitial lung disease, this is not the time to take measurement for the pulmonary hypertension. Wait until the patient acute exacerbation settles down, and then you can start looking for the pulmonary hypertension. So, evaluation of pulmonary hypertension and chronic lung disease is important. You can suspect the disease by patient clinical symptoms, functional disabilities, certain imaging that can support the presence of pulmonary hypertension. And you can support it by looking at the echocardiogram and finding high probability for PH, and then you can confirm that by doing a right heart catheterization. And then after that, you have to stratify your patient. Is your patient having group 1 versus group 3? And that depends on the physiological severity and the morphological severity of the imaging. So if you have somebody with limited chronic lung diseases, not very much obstructive or obstructive defect, minimal emphysematous changes, minimal fibrosis, most likely you're dealing with group 1 PH, and they have mild lung disease with it. So you have to follow the treatment algorithm for group 1. However, if you have somebody with severe chronic lung diseases, significant obstructive defect, significant restrictive defect, significant changes on the CT scan, significant emphysema or interstitial lung disease, likely you're dealing with group 3. And at that time, you have to refer your patient to the expert center for further evaluation. As I mentioned, majority of your patients will be in the mild to moderate PH, where no route of PH targeted therapy in these patients. However, if your patient has significant severe pulmonary hypertension, individualized care should be followed, and this patient might actually get benefit of certain PH targeted therapy in expert center. So I'm going to talk for this presentation about the PH in ILD more, and if I have time, I will touch on PH in COPD. So ILD is a heterogeneous group of disease characterized by both interstitial and pulmonary vascular component. If you look over here, you have a normal lung, you have the parenchyma, you have infiltration of immune cells, dysregulation of immune response, expansion of the fibro and myofibroblast, then you have scarring and adhesions of the alveoli. And you can tell there is a very close superficial relationship between the alveolar wall and the capillaries, and this is actually the fundamental precondition for developing of pulmonary hypertension, because you can have vascular cell changes, so around the vessels, cytokines, and dysfunction to the endothelial, vasoconstriction, hypoxic vasoconstriction, imbalance between vasoconstriction and vasodilatation. You end up with capillary bed destruction and development of PH in ILD. So PH has, for this reason, PH has been reported to be up to 86% in patients with interstitial lung diseases. And again, PH and ILD contribute to significant morbidity and mortality. PH and ILD associated also increased risk of exacerbation of the underlying ILD and sometimes of the underlying IBF. So in PH and ILD, you will find patients that have reduced DLCO disproportional to their measured lung volumes and worsening gas exchange. You will have patients with reduced oxygenation. They have rapid in their oxygenation with only minimal exertion. They require high oxygen to maintain high oxygen requirement just to maintain their SpO2 acceptable more than 90%. And they have significant dyspnea and reduced exercise capacity or tolerance. You can see that the prevalence of precapillary PH in ILD is basically an IBF depending on the stage. It can be reported up to more than 60% in patients with end-stage IBF. In patients with the entity of combined pulmonary fibrosis and emphysema, it can be reported between 30 and 50%. Patients with connective tissue disease, it can be reported up to 20%. Sarcoidosis, you have also a wide range of prevalence between 5 and 70%, depends on the source. So should we screen our patients with ILD for the presence of pulmonary hypertension? I believe yes, you should have an index of suspicion to developmental of the PH in patient with ILD. And you can predict this non-invasively by looking at symptoms and signs. You can learn that from DFT, as I mentioned, reduced DLCO, significant desaturation, in cardiopulmonary exercise testing, they can have high ventilatory equivalent, hyperventilation, horrible gas exchange. CT chest, you can also look at the diameter of the PA. vessels, also high levels of biomarkers, echocardiogram, MRI. So in terms of the right heart cath, I guess we will learn that there is actually pros and cons of doing this. So it's still an invasive procedure. Still, the patient will be having a procedure sometimes without an outcome because we still don't have specific therapy for group 3 PH. However, this procedure can be done if you're thinking that your patient is a candidate for transplant or a candidate for clinical trials. So in terms of the treatment of the group 3 PH related to ILD, the PH targeted therapy was studied extensively over the last few years, and it was actually not very, we didn't show very good results. For example, using pulmonary vasoactive drug, basically in these studies was only addressing the ILD irrespective of the presence of the pulmonary hypertension. So they didn't care whether the patient has pulmonary hypertension or no. They just addressed pulmonary vasodilator on patient with ILD. And you can tell most of these patients actually have negative studies, or most of these studies were negative for presentin, macitentan, and presentin sildenafil. 2 studies only were for sildenafil, did show somehow maybe positive studies, especially in the second one. The STEP IBF study was done by using sildenafil in 180 patients, 1-to-1 randomization, patient with IBF, 12-week study. Primary endpoint was changing in the 6-minute walk distance. It was actually a negative study. Reason for that, they chose IBF with DLCO less than 35%, irrespective of presence of pulmonary hypertension. Then after that, they moved to the other study where they used the same population. However, this time they looked specifically for patients with presence of somehow RV, systolic dysfunction, or RV dysfunction, the STEP IV RVSP. So in this study, as I mentioned, they studied sildenafil in patients with advanced IBF, DLCO less than 35 in more than 14 centers. And again, these are the same population for the previous study. Only certain number of patients had available echo for assessment. They randomized them for sildenafil versus placebo, and then they did the analysis retrospectively. And they used sildenafil at a dose of 20 milligram TID. What did they found? They found that sildenafil actually did improve the walk distance by almost 99 meters, sildenafil in patients specifically with RV systolic dysfunction. So not only IPF, not only bad disease, but presence of RV dysfunction. Sildenafil also improved quality of life and improved St. George questionnaire. But these patients, they should have at baseline some sort of RV dysfunction or high RVSP. Then this study was actually done, and this time they looked at the effect of the antifibrotic agent and sildenafil with the antifibrotic agent in patients with idiopathic pulmonary fibrosis. Again, they added nintedanib to sildenafil, IPF, low DLCO. Primary endpoint was changed at the baseline, total St. George respiratory questionnaire, and they have more than 24 pre-specified other outcomes. So RCT, double-blinded, placebo-controlled trial, 13 countries. They looked at nintedanib plus sildenafil versus nintedanib alone, and the study was actually negative for primary and secondary endpoints. They had about 30% of their patients with combined emphysema with fibrosis, and again, you can tell why it was a negative study. About only 40% of the patients, they had evidence of RV dysfunction, so probably they did not target the right population. So I would say this was pretty much negative study. So then we come to these type of studies that were done, and this time they actually tried to choose the right population by choosing by adding pulmonary vasodilator therapy, addressing primary pulmonary hypertension. Again, multiple studies was done, and you can tell Resig with sildenafil presentin were negative in couple studies, and then actually presentin was positive in one of the sarcoidosis study, only in improving hemodynamic, and we'll talk about the nitric oxide study and the inhaled treprostinil. So the nitric oxide study was done by Steve Nathan. It studied the effect of the inhaled nitric oxides in pulse therapy and physical activity in patients with ILD and risk of pulmonary hypertension. And their endpoint was the improvement of the 6-minute walk distance and also the improvement of the actigraphy. And they measured the baseline physical activity and also the vigorous physical activity. So this is their randomization for the study. Randomized people to either the INO or the placebo. And in terms of underlying IPF, the patient had more than 73% of the patient had IPF, and some of these patients have background therapy of antifibrotic agent. You can tell here the study was positive of the 80% improvement of the physical activity and the maintenance of overall physical activity in the inner group, and the placebo there was drop in the physical activity and 12% in the overall activity. So you can tell from this study, INO was safe, well tolerated, and did not affect oxygenation. However, the study was small, the treatment duration was relatively short, percentage of subjects with complete activity data was actually less in the treatment group, and patient had slight imbalance on the underlying cause of interstitial lung disease, and only 70% of these people have high probability PH in their echocardiogram. Again, probably not the right population. For this, a phase 3 trial now is ongoing for the effect of inhaled INO in patients with fibrotic ILD. So the INCREASE trial is the recently published trial in the New England Journal about the inhaled treprostinil effect in pulmonary hypertension due to the interstitial lung disease. So this is an RCT, multicentric, double-blinded, placebo-controlled, 16-week trial. The study was done to evaluate the effect, the safety and efficacy of the inhaled treprostinil in patient with pH-related ILD. And the patient required the diagnosis of ILD to be done by CT scan at least within 6 months, and the pulmonary hypertension by right heart cath for at least 1 year. And they compared this in a significant number of patients, over 300, and the treprostinil was administered by the means of the ultrasonic pulse delivery nebulization, in average of 12 breaths, about 4 times daily. So about the patient characteristic, again, heterogeneous group of ILD, about 44% of the patient population had idiopathic interstitial pneumonia, 25% they had combined pulmonary fibrosis and emphysema, and about 22% they had connective tissue disease. Mostly they used oxygen, and some of them, about 13% were in pirfenidone, and only 10% were in nintedanib. Majority was not in background antifibrotic therapy. So what's their primary outcome? The primary endpoint was the difference in the change in the peak 6-minute walk distance from the baseline to the week 16, and the secondary endpoint is the change in the NT-proBNP level. So at week 16, we can see there is significant improvement over here. So actually, the least square mean difference between the groups in the change from the baseline to 6-minute walk distance was 31 meters. I would say this is the minimum of important clinical significance in the study to see improvement of the 6-minute walk distance by 30 meters, which it did have significant p-value. There was also reduction of the NT-proBNP level to the baseline, about 15% of the patients of the treatment group compared to the increased proBNP level in 46% of the placebo. So the study was positive for improvement of the functional capacity and improvement of the biomarkers. Again, they studied clinical worsening, and it was seen in 22% of patients in treprostinil group and about 33% in the placebo group. So they consider this as a positive study. What about the side effects? So the frequent side effect was seen in the two arms actually was headache, dyspnea, dizziness, nausea, fatigue, diarrhea. In patients with inhaled treprostinil, they had more of throat irritation, oropharyngeal pain, and this related to the inhalation treatment. However, there was no effect of the inhaled treprostinil to the PFT, and there was no significant change in the pulse oximetry or the supplement oxygen. And this is usually the concern about giving pH-targeted therapy in patients with ILD, the concern about worsening the PQ mismatch. However, this was not seen in this study with the inhaled treprostinil. So the trial was of short duration. 20% of the patients, they actually discontinued the medication prematurely. So they considered this trial trial to be a landmark in the management of the PH-ILD, and they considered the medication actually was positive in improving exercise capacity, reducing NT-proBNP level, and lower the risk of exacerbation, clinical worsening versus placebo. So for this, treprostinil became the first agent got approved from the US FDA in management for patients with PH-ILD. So, in terms of the recommendation of the last NIST guidelines in 2018 in management of the PH-ILD, this is based on the recommendation that they did not, that re-cigarettes and ambrisentan were actually contraindicated in patients with idiopathic interstitial pneumonia-related pulmonary hypertension, and that based on clinical trial did show harmful effect and lead to the early or premature stop of the trial. There was no evidence of benefit for other endothelin receptor antagonists in idiopathic interstitial pneumonia-related pulmonary hypertension. Data on sildenafil was actually conflicting. Evidence of prostanoid therapy was too limited for any current recommendation, and further RCT was actually encouraged. PH-ILD associated with increasing morbidity and mortality. Echocardiogram can help you to screen your patient for PH. However, it lacks sensitivity and specificity compared to group 1. RHC remained the gold standard to confirm the diagnosis. However, it should only be reserved and done in patients where specific management decision is based on that. For example, enrollment of RCT or lung transplantation. There was a little debate about using supplement oxygen and diuretics in treatment of PH-ILD. However, we all do it. The previous study of the vasoactive medications on PH-ILD has also confirmed that sildenafil PH in PH-ILD is unlikely to be harmful. However, there was a lot of noise about sildenafil. It's unlikely to be the magic drug to extend or to cause to increase life expectancy in patients with ILD-PH, but it can be used as a bridge to transplant. It can be used in patients to improve functional status. We know that it can improve functional capacity in patients with significant RV dysfunction, and also quality of life if this patient is not a transplant candidate. There is no approved specific treatment for PH-ILD so far, but however, I think there is a new inhalational approach now is the inhaled nitric oxide, especially the inhaled NO and inhaled treprostinil. They may hold promises that this will change the future. My last slide about the transplant, that PH-ILD is devastating prognosis with limited treatment option, and lung transplant should be considered as a viable option, and suitable candidates should be counseled early about this option with early referral to the transplant center. From here, I will stop my presentation. I'll be happy to take the questions at the end of the session. Thank you so much.
Thank you very much, Dr. Arda. Thank you very much for this excellent talk. We will leave the question at the end. The next speaker will be introduced by Dr. Arda.
So it's my great pleasure now to introduce the next speaker, Dr. Hani Sabura, from the consultant cardiologist from the Cleveland Clinic in Abu Dhabi, UAE. Is he with us? Yes. So Dr. Hani is recently assigned as a clinical assistant professor of medicine and cardiology at the Brown University at Albert School of Medicine. His interest in the management of arrhythmia and advanced congestive heart failure and pulmonary hypertension, as well as cardiac imaging. Welcome, Dr. Hani, and the floor is yours.
Thank you very much. It's always a pleasure to be part of this meeting. This is in fact, one of the highest level meetings I've had the pleasure to attend. The level of scientific presentation here is really phenomenal. So I was given a very difficult topic. Thank you very much to the President and the Chairman. And the topic actually was looking at complex post-repair patients with congenital heart disease. What's the treatment response? So I'm going to try to drill down on this topic. It's really a small topic, but it's very important and very interesting. So the medical therapy responses of patients with complex congenital heart disease are variable, and unfortunately a lot of the literature we have are from case reports and not a lot of systematic studies. So I like to call this topic between a rock and a hard place, because as clinicians we have to make decisions. Sometimes the evidence isn't entirely there, but you see a patient who's failing or is on the wrong track, so you have to put your best foot forward. And this is the difficult PH patient situation, and particularly the one that is most difficult for us is the congenital complex heart disease. So these are my declarations and conflicts of interest. So overall, congenital heart disease is important. It's increasing. A lot of these patients survive to adulthood due to very complex medical and surgical interventions and due to the expertise of our pediatric surgeons and pediatric cardiologists. And the age is actually increasing, so these patients will develop conventional comorbidities as well. In the U.S., about 5% increase. Now, the PH associated with congenital heart disease, while it's rare, this is actually very important because a lot of patients with these common defects, ASD and VSD, will develop pulmonary hypertension, and we don't have national screening programs. And this is a key point. So you're going to find these patients in the pulmonary hypertension clinic when it's a little bit late, or worse, when they're pregnant with pulmonary hypertension, which is the unfortunate thing that we see right now. VSD is more likely to develop pulmonary hypertension, the larger, the more likely. So this is a Concord database. It's a very large longitudinal database of adult congenital heart disease. Over time, 15% of ASD, 11% of VSD get PH, and these patients will progress to Eisenmenger syndrome. So this is a very serious problem, and the upstream detection is key in these patients. And if you consider congenital heart disease back in 2002, and now it's 20 years later, these numbers are actually increasing, probably because of screening, early detection, or other issues. Now, in the European data, it's a little bit more rigorous because they actually have screening programs in Europe. There's about 1.2 million in Europe. 5% of congenital heart disease. It accounts for 50% of PH in children. The mortality and morbidity are greater. There's a tenfold increase in mortality once Eisenmenger syndrome develops. And that's why we have to prevent pulmonary hypertension by early diagnosis and treatment. And very important to recognize Eisenmenger syndrome, you can actually reverse some of the pathophysiology with targeted therapy. So there is a lot of things you can do with Eisenmenger syndrome. Unfortunately, these patients are often managed in general practice, never come to the PH center, never get the proper treatment and develop complications. And one of the things that's really important, and having done this review, is that there is a lot of similarity between children and adults with pulmonary arterial hypertension. The guidelines are similar, but I'm going to show you there are subtle differences as to when you do certain procedures and when you treat. So there is a commonality, but there are some important definition changes. So this has not changed in the current set of guidelines for the CHD, congenital heart disease, PH. Eisenmenger being the worst, this is the reverse shunt, and as you leave this, it gets worse. So you do have to attach yourself to reducing the pulmonary vascular resistance. It does have an impact on these patients' comorbidities. Now, there are patients who have pulmonary hypertension who accidentally have a shunt, where you believe that the shunt defect, the increase in PVR is mild to moderate, and it's still left to right, and there's no cyanosis. You then have patients with small defects. So this may be a patient with pulmonary hypertension who has a small defect. Closing the defect is dangerous, but it's also not the cause of the problem. And I think these two are very difficult to sort out unless you have a center of excellence that is both congenital heart disease and pulmonary hypertension working together with an MDT. And this, of course, is the residual. These patients who are closed either late or incorrectly, and they have residual pulmonary hypertension. Actually, these people have the worst survival, because if they are closed incorrectly, you have literally disturbed the balanced physiology. And unfortunately now, interventional cardiology has developed to the point that anybody can do an ASD closure. Anybody can do it. As simple as doing a stent with these closure devices. So I really think we have to be very careful about the indication of closure, and really any closure has to be reviewed by the PH and the congenital heart disease people as well. So the systemic to pulmonary shunts are common with any VSD. Sinus venosus is one of the missed ones. Truncus arteriosus always causes a shunt. It's really a kind of a serious situation. So for those of you who are not cardiologists, I will try to explain this pathophysiology as simply as possible. Generally, if you have an uncorrected shunt, there's left to right flow. So it goes from left to right, low pressure, high pressure, increases the pulmonary blood flow, shear stress, endothelial dysfunction, and vascular remodeling, increases pulmonary vascular resistance over time. Reversal of the shunt now occurs, so now you have cyanosis, and this is Eisenmenger syndrome with all of its complications and death. So targeted therapy has been looked at systematically when you have reached this stage, increased pulmonary vascular resistance, and once the shunt reverses, preferably earlier than that, and especially in patients where you have this therapeutic window before the RV function fails. Because once the isomingler patient fails, it's done. It's got to be a transplant, and it's got to be done very quickly. So one of the points that comes up, and I referred to it in the previous couple of slides, is detailed hemodynamic decision-making, even for an ASD. ASD closure is the simplest closure that occurs. It is also technically not very demanding, so unfortunately, multiple non-expert centers are doing it. But these are the rules. These are the rules. And I've seen patients get closure without a right heart cath. They just pop in this Amplatzer device. It's ridiculous, really. So this is the basic rule. The PVR has to be less than forwards units. The ACC update also tells you that the PVR-SVR ratio has to be a third at least, and the PA pressure has to be half of systemic. That means detailed hemodynamics have to be done in this decision-making. This is the group that you should not touch. Don't do it. PVR more than 8 Woods units. And in addition, the ACC guidelines are even more rigorous. The systolic PAP is about two-thirds systemic. So it's about 60 when the blood pressure is 100. PVR, SVR, again 60%, and predominantly a left to right shunt. Who does this kind of hemodynamics in an outpatient setting, in the outside clinics? They don't do it. Now this is the group that is very controversial. This is the maybe, treat, and close. Again, it's a lot of hemodynamic data, and it really needs a teamwork to look at. So to summarize, you could consider in a center of excellence with a lot of expertise and follow-up, if there's a net left to right shunt, if the PA pressure is 50% systemic and the PVR greater than a third of the systemic resistance. So very careful hemodynamics. Do not close if the PA pressure is greater than two-thirds, PVR is greater than two-thirds, and or a net right to left shunt. Now with the consider, there's a big star and a careful consideration of a fenestrated device after hemodynamic assessment. So there's a lot of reasons to think about this carefully. Where should the decision-making be done? Again, clearly in the guidelines. These intermediate PVRs are individually selected in specialized centers with expertise in both PH and congenital heart disease, particularly pediatric cardiology. The MDT carefully weighs risks and benefits of procedure, characteristics, expertise, local post-operative care, and most importantly, if it doesn't work, can these patients be given long-term vasodilator therapy? Do they have access? Is cost an issue in this particular scenario? So this is a key point of the decision. If you can't follow them and can't give them treatment, don't do it. Leave them alone. So in the pediatric PH literature, and this is the updated ATS-AHA pediatric guideline, this is the important point that's not present in the adult guidelines. This is the acute vasoreactivity testing. So in adult cardiology, we don't use vasoreactivity testing in congenital heart disease because by that time there's a lot of remodeling. These pediatric patients, there's some age criteria that are utilized here. The importance if they have a feasibility or they're intermediate with their PVR or the PVR-SVR ratio, you have to do vasoreactivity testing with nitric oxide. If it's positive, then you can operate or close. But in these cases where the risk is a little bit higher, you can consider fenestration. If it's negative, targeted therapy, repeat catheterization. So then usually dual therapy is given. Repeat the vasoreactivity testing. Consider high-risk fenestration. If it's negative, inoperable. It's a more complex algorithm, requires multiple steps, but you see the follow-up requires the ability to demonstrate continued vasoreactivity and treatment response. So this is the important difference between pediatrics and adults. And this is derived from the long-term registries in pediatrics. Acute vasodilatory therapy to determine operability, potential deployment of treat and repair in pediatric patients previously deemed inoperable. So treat and repair actually comes from the pediatric literature, not well validated in adults. I think this is a key point that we have to think about. So the actual nomenclature is treat, observe closely, maybe repair. It's not treat and repair. Treat and repair sounds like it's automatic, complex, controversial. It allows possibility for repair for unfavorable hemodynamics, especially if they have improvement, response to acute vasodilator therapy after a course of targeted PH therapy. It must be acknowledged that data is needed to support this approach, particularly in adults. This is well validated in pediatrics, but not adults. So again, the caveats, decision and optimal vasodilator therapy, what dose, how long, we don't know. Timing of therapy still to be determined. High-risk patients on this treat, observe, and repair need careful post-operative follow-up to evaluate mid and long-term results. This is a key point here. The response to therapy is important. These patients who have improved vascular resistance with acute vasodilator therapy could be high risk for closure, but could go with a fenestrated device. So you're going to continue the therapy and fenestrate the device to allow a pop-off valve. Because if you close it completely, the RV will start to fail. Non-improvement after PH therapy, unresponsive to repeat acute vasodilator therapy are inoperable and probably need to be listed for transplant. So Fontan is the most complex of complex congenital heart disease. And again, I am going to try and explain this surgical physiology. It's created something invented by a couple of brilliant surgeons, Fontan, Baudet, and Guillermo Hertzer, in the 1970s. So what you do is you have a single ventricle. In order to allow the blood to enter the systemic circulation and be oxygenated, you basically disconnect the venous circulation and connect it directly into the pulmonary artery. So you have now two separate circulations. They're not connected, right? There's no RV. There is no pump. This circulation, the lung blood flow, is entirely dependent on intrathoracic pressure only. That's it. So it operates at a much, much lower pressure than physiological. And this is the 10 commandments of Shusat. Shusat worked with Fontan, and in 1977, they published the 10 commandments. And the two most important ones you see right here. Mean PA pressure less than 15 in order for this to stay open, and PVR less than 4 Woods units. So this is a key point, and that means for these patients to survive, they must have a super low pulmonary vascular resistance because it's essentially passive filling. There is no pump. So this is really important, and this has been studied really quite systematically. Even though Fontan is a complex procedure, they are followed very closely. So after Fontan, pulmonary vasculature is reactive to nitric oxide with reduction in PVR. Significant responses to pulmonary vasodilator therapy have been seen, and therefore developing a protocol for vasoreactivity testing to determine post-Fontan who is going to benefit from therapy in the long-term follow-up. Vasodilator therapy in Fontan, which medications? So there's a lot of studies. Unfortunately, they're small studies, and you can imagine why. Sildenafil, bosentan, and subcutaneous treprostinil have shown benefit. The largest systematic study is from this group here in Ottawa, I think. They enrolled 18 patients being considered for heart transplantation. So they're either going to heart transplant or get them on remodeling. So they were placed on, or treprostinil to be accurate, based on a failing single ventricle hemodynamics. So they had careful hemodynamics and something is progressing. 18 patients received treprostinil, and they had 6 stage 1 Glenn, 6 stage 2 Glenn, and 6 op Fontan. So basically these are stages of the procedure, not technically important. Significant improvement in O2 saturation and PVR in each group. In addition, 50% of the initially ineligible next stage, so you cannot go to the next stage of the surgical treatment, could undergo the stage 2 or 3 palliation after treatment with treprostinil. 4 patients eventually underwent transplant. So this is very powerful because this is also obviously the agent that we go to when we have adverse physiology. So even in the absence of typical post-Fontan complications, patients can experience Fontan failure related to elevated transpulmonary gradient alone that limits cardiac output and exercise. Fontan failure has a lot of horrible complications. I won't go into it, but the hemodynamics are sort of key and can be detected. The typical hemodynamics in these patients should show low atrial filling pressures and low ventricular and diastolic pressures and elevated Fontan. So that's the circuit pressure. Again, this is a circuit driven by literally intrathoracic pressure and breathing. So you cannot convert the Fontan to a pump to overcome this resistance. Thus, pulmonary vasodilator therapy is very important in this group to address this unique, complex surgical pathophysiology. So along those lines, there's a lot of high-risk patients that may be ineligible for stage palliation with an elevated PVR. You can't go forward in surgery of the PVR that may be benefiting from pulmonary vasodilators. And clearly, a low pulmonary vascular resistance is essential for the functioning of this Fontan patient. So even if heart transplantation is the best long-term option, pulmonary vasodilator therapy can reduce cyanosis, improve exercise tolerance, and functional class so that they can survive until they get their transplant. So some of the results here. showed, I'm sorry, I think we skipped the slide. So there's a important randomized meta-analysis. I think there's a missing slide here, I apologize. So there's a large meta-analysis which was published from a group in the United States. They looked at about 325 patients overall, pediatric, adult, and so on, who were given vasodilator therapy. So the results of this study was reduction of mean pulmonary artery pressure significantly. There was no significant change in BNP or NT-proBNP. There were no side effects, mild adverse effects that you know from vasodilator therapy in general. So they looked at 9 randomized studies, about 381 patients with Fontan, and the pulmonary vasodilator therapy led to significant improvements in functional class, 6-minute walk distance, 134 meters, and remember, we didn't see that in the MERIT study. Peak VO2 was significantly improved, and as I mentioned, the hemodynamics by cath were improved as well. So the conclusion is that the meta-analysis showed the primarily PDE5 and endothelin antagonists improved hemodynamics in Fontan, functional class and walk. Peak O2 consumption was improved. BNP was not significantly reduced or mortality, but pulmonary vasodilators were well tolerated and beneficial in these patients. And just to give you a picture, just to remember, these young people, these are young people with pulmonary vascular disease. This is an autopsy of a 14-year-old patient who died. And I think, was that the last slide? Yeah, this is actually the last slide. This is the progression in patients with Eisenmenger syndrome. And if you find the patients at these earlier stages where remodeling has happened before the patients develop the inoperable severe formation, this is where vasodilator therapy has a role, and I think we have to look at these patients in a very detailed and methodical fashion. Thank you very much.
Thank you very much, Hani. We will leave the question at the end. Stage here with us, and we will do the question session at the end. I'm pleased to introduce the next speaker, Dr. Siham Al-Rashidi. Dr. Siham is a consultant rheumatology at Prince Sultan Military Medical City. She is a member of the residency training program and hospital ethics committee. Dr. Siham is a regular speaker at Saph. She will be talking about scleroderma associated pulmonary hypertension. Dr. Siham, please.
Thank you so much. Thank you so much for the invitation and nice introduction. So my topic today will be talking about scleroderma pulmonary arterial hypertension, early detections and intervention, and what is the impact on the outcome. So as you all know that PAH is a well-known complication of systemic sclerosis. It is the second leading cause of death. Most patients unfortunately present with severe symptoms, severe hemodynamic at time of diagnosis. Survival after diagnosis of PAH is poor. The prevalence of PAH in scleroderma patient varies between 7 to 19. It is quite sufficiently common to justify screening. Euroregistry still observe up to 85% of patients in NIHA class 3 to 4, which is unchanged from the NIH registry, which was published 30 years ago. It accounts for 30% of death in systemic sclerosis patients. Therefore, early detection through a systemic clearing of asymptomatic patient has the potential to identify PAH at an early stage. So I will focus in WHO Group 1, which pathologically characterized, as you know, that proliferative remodeling of small pulmonary arteries, and clinically is defined during RHC by the pulmonary artery pressure more than 20, which pressure less than 15, and BVR above 3. Despite of recent medical advances and effective therapy of PAH, annual mortality remain high and worse in scleroderma. So these are the three main parts: early detection, intervention, and then the outcome. So there are a few points I would like to highlight in the early detection. One is epidemiological concept for PAH screening program, lead bias time, overdiagnosis, and true screening. And the second, composite screening algorithm, the European, the Australian, and the US, and the future screening study. In the intervention part, we'll talk briefly about the RV dysfunction in scleroderma, risk stratification, and PAH-specific therapy. For the epidemiological concept for PH screening program, the first one is what is called lead time bias. What does it mean? The survival appear better only because the diagnosis is made earlier in the disease course, with the patient being observed for a longer period of time, but actual life expectancy is unchanged. I'll explain that in a few minutes. The second is overdiagnosis, which again could happen when PAH is detected at early stage, but early detection does not affect the outcome if other risk factor unrelated to PAH result in death. This is particularly relevant in elderly patients with systemic sclerosis, especially those with severe GI involvement or advanced interstitial lung disease. Okay, this is the explanation for the lead time bias, as you can see here. The observed survival time when it's detected by the PH detected by screening appeared longer than the observed survival time when the diagnosis was made from the symptoms, while in fact the death or the life expectancy remain unchanged. Again, for the overdiagnosis, PH detected in screening and the death was resulted due to non-PAH related, so the death due to PAH was later or expected later. The third concept is through screening. Many screening studies involved patients who had symptoms already. The inclusion of symptomatic patients increase the pretest probability prevalence of the disease in the population. Again, potentially overestimate the observed benefit-risk balance of a screening program compared to with one in truly asymptomatic population. So these are the DETECT and the ARS and the Australian algorithm. They are well designed and validated by various organizations and society. And it is implemented across institution and clinician. So for the DETECT, it is an evidence-based screening algorithm with objective of minimizing the number of missed PH diagnoses. It is limited with patient with disease duration more than 3 and DELCO less than 60% predicted. So they are targeting a high-risk patient. RSC and echo performed systematically. So it combines two steps. First step is the non-echo variable, and the second is the echo variable, TRV and right atrium. This is a closer look for step 1. The non-echographic variable include FVC over DELCO, telangiectasia, anticentromere antibody, ProBNP, serum urate, and right axis deviation in ECG. And this is calculated through a web-based calculator, and if the total score above 300, if the total score above the 300, it will be shifted and refer the patient to the echo. And again, they will look at the right atrium and the TRV velocity, and if the total score above 35, the probability is high for PH, and the patient will be referred to right heart cath. For the 2015 ARS, it is mainly based on echo variables, so they categorize the patient into low, high, and intermediate according to the TRV velocity. So if the TRV more than 3.4, they will go for the next step, which evaluate more in the RV morphology and function in the ventricle, pulmonary artery, and IVC. Again, for the intermediate risk, it will be if less than 2.8 TRV or between 2.9 and 3.4. So if there are any other symptoms suggestive of PH echo, they will refer for the second step for further evaluation. This is the Australian scleroderma interest group algorithm. Again, it combines the BFT and ProBNP. So if the DELCO less than 70 predicted and the FVC over the DELCO above 1.8 and or BNB above 200, so the patient will be referred to echo and other needed investigation option like HRCT, VQ scan, 6-minute walk test. If suspected, the patient will refer to RSC. So among the screening algorithm, there are some differences in the form of cost and the performance of more. For example, they have more percentage of right heart cath. Detect has a high sensitivity and high negative value, while the Australian has more specificity. Again, this is the recommendation for pulmonary arterial hypertension screening. For resting echogram is recommended as a screening test in asymptomatic patient with systemic sclerosis. This is class 1 level of evidence is B. And when clearing in echogram, stepwise detect algorithm may be considered in adult scleroderma patient with more than 3 years disease duration and DELCO less than 60 predicted. This is a class 2B level of evidence is B. So what are the future screening? Nail capillaroscopy, as you know, density is lower in systemic sclerosis associated with hypertension patient and correlate with the symptoms and the resting main pulmonary artery pressure. Another interesting screening chemokines, which is the CCL motive 21, which is responsible for T-cell differentiation. Also, it has a role on the tumor, was found to be higher in patient in systemic sclerosis, PH related from 2 independent cohort versus control. Patient with systemic sclerosis with interstitial lung disease and patient with systemic sclerosis without PH and idiopathic PH. This is the RV in systemic sclerosis. They found that the adaptive RV in systemic sclerosis is different than the idiopathic. So the intrinsic RV contractility of the RV in scleroderma is diminished. And this is maybe linked due to the decreased angiogenesis within the hyperatrophied right ventricle. So this is maybe a potential or a target future therapy to assess more and treat the RV function in scleroderma patient. The researchers have been focusing on finding a non-invasive tool to assess the RV, and they suggest that RV longitudinal systemic strain is worse in systemic sclerosis associated pulmonary hypertension patient compared to the idiopathic patient. The risk stratification, as we heard from the previous lectures, to provide diagnostic information, guide therapeutic decision, and recommend to initiate targeted therapy based on risk stratification. When these models were applied, it confirmed the accuracy of the guidelines risk table in predicting patient survival. Based on variable and cutoff values established by expert consensus, there are 3 or 4 risk categories were defined with estimated 1-year mortality range from less than 5 and considered low risk, and if more than 10% risk considered as a high risk. The 3 approaches most commonly used are the Compera and the French and the Reveal 2. Compera is a European BH registry, and as you can see, the red refer to the high-risk group, intermediate for the yellow, and the green for the low-risk group. And the variable include the WHO functional class, 6-minute walk test, pro-BNB, BNB, right atrial pressure, cardiac index, and mixed venous oxygenation. This is the reveal, again, contain more variables, as you can see, and the fringe is almost contain 4 variables. And according to the risk score, the patient will be categorized into low, intermediate, and high risk. So once the patient systemic scleroderma pH diagnosed by RHC, risk stratification, by reveal that if the score below 8 and the functional class between 2 to 3, dual combination therapy, and if the patient high risk and the reveal score above 9 and WHO above, 4, dual combination therapy with prostacyclin analog. And you will follow the patient. And more importantly, is to follow and reassess your patient to reach a low-risk group. So the risk assessment in 3 to 6 months, if remain in low risk, continue regular follow-up every 6 months, and in the intermediate and high risk, if the reveal above 9, triple therapy, reassess again in 3 to 6 months, and they remain again, so you consider for lung transplant. For lung transplant in scleroderma, you have to be very careful because the risk of aspiration and deformity of the chest and other associated organ in scleroderma patients. So sometimes it might be a palliative treatment. So this is the pH-specific therapy targeting the main pathway, which is nitric oxide, endothelin, and the prostacyclin analog. Again, these are the famous study that RCT trial that you are familiar with. The prostacyclin analog, my previous colleague, they talk about all the differences and the effect of these prostacyclin analog, and these are the RCT trial on the prostacyclin. Phosphodiesterase inhibitor, sildenafil and tadalafil, again, well known to the PH people, risegwat, sildenafil, and these are the endothelial receptor antagonist bosentan, and the studies breathe 1, 2, and 5. And mainly they are looking for the primary endpoint in most of the pH targeted therapy in the 6-minute walk distance, which is again might be affected in our patients, especially they have musculoskeletal symptoms, so it might be not the optimal primary endpoint for those patients. And macitentan and the Saph, they look at the time to clinical worsening. And the tremendous change is not the discovery of a new pH targeted therapy. It is in fact due to the combination therapy. And interestingly, that the macitentan with sildenafil has effect on the vasodilatory effect on the RV in scleroderma patient. Okay, so what about the outcome? So the data are conflicting. No change in survival as reported by REVEAL, which is a registry to evaluate early and long-term pH management in US. The 3-year survival was 51% for a newly diagnosed systemic scleroderma and 61% for a previously diagnosed scleroderma. And again, this is some of the characteristic of scleroderma patient in REVEAL study. They have high prevalence of pericardial effusion, higher pro-BMB, and even worse than among the other connective tissue diseases. And again, this is the survival. This is Kaplan-Meier 3-year survival curve. Compare patient with systemic scleroderma pH associated versus pH associated with connective tissue disease. And again, the survival is better in non-scleroderma connective tissue diseases. So another systemic review, a meta-analysis, 22 study between 1960 2012, there was no change in survival. Again, 3-year survival, 52. French registry, 513 incidents. Scleroderma patient reported the 1, 3, and 5 transplant-free survival rate, 87, 55, and 35% respectively. Again, another cohort study, 132 scleroderma patients to identify the predictor of mortality. 45% died, and the median survival time for PH diagnosis was 4 years. Another study, which was 14-year observational study, and change in modern era of oral vasodilator, 5 years survival was 51 and scleroderma. In comparator registry, the low-risk connective tissue disease had only 64% at 3 years, and high-risk patient had 34 3-year survival. What about the other study in favor of improving survival? So this study published in Heart 2006 and measured the survival hemodynamic functional cost in 2 treatment era, 6 years of longitudinal of 92 patients, prospective and retrospective. Historic group was 47 patients were given a basic treatment and prostanoid when indicated, and the treatment era group was in 45 patients. Historic control group was having 68 at 1 year and 47% at 2 years. And in the treatment era was 81 and 71 at 1 and 2 years, respectively. Another cohort of 16 patients with scleroderma, newly diagnosed with PH enrolled in French registry between 2002 and 2003. And detection cohort 16 patients with scleroderma who were screened for echo and subsequent RC confirmation. In the early detection cohort, hemodynamics and symptoms were milder at the time of diagnosis. Again, the long-term survival is significantly better in the detect cohort with 64 of patients still alive at 8 years, only 17 of systemic scleroderma associated with hypertension patient from a routine practice cohort. The FARIS is again one of the largest study in the US, and the study reported better survival rate at 1, 3, 5 years of 95, 75, and 63, which have been related to the early diagnosis at early stage, the disease due to more widespread screening of patients with scleroderma. Again, 59% of patients in NIHA class for 1 to 2, as opposed to only 31 in REVEAL and 27 in the recent French registry. This suggests that early diagnosis and treatment could translate to a better long-term outcome. Better survival rate in FARIS study could also potentially attributed to the lead time bias. This is the last latest study, which was meta-analysis of 11 RCT and 19 registry, published in Arthritis and Rheumatism in 2021. Long-term outcome in patients with connective tissue disease associated with arterial hypertension in modern treatment era meta-analysis, combined control trials, and observational registry. The objective to quantify the benefit of modern therapy in patients with connective tissue disease, PH. It was a PubMed and M-based database were searched for article reporting data from ARTS randomized control trial or registry published between 2000 and 2019. For RC to be included in the trial had to be evaluated and approved therapy and long-term of clinical morbidity and mortality, or 6-minute walk distance had to be reported. For the registry to be included, survival rate had to be reported. Again, the result, 36 reduction in the risk of mortality and morbidity events in both in the overall PH population. The survival was lower in connective tissue disease, 62 versus 72 at 3 years survival. Survival rate in connective tissue disease primarily after 2010 was higher in connective tissue disease before 2010 73 versus 65 at 3 years. And these are the diagrams just to show the overall survival between the all pH group and connective tissue pH associated. And the second B is to show there is an increase in the survival after 2010 in comparing to before 2010. And the last is the difference between connective tissue disease survival between scleroderma and lupus patient, which was expected, as you all know that the immune suppressive therapy does work in other autoimmune, but it is refractory in scleroderma. So I will conclude my talk that pH-associated scleroderma is a devastating disease and there is no cure. So early detection with a systemic screening could lead to early diagnosis and improve outcomes. Identification of a novel marker for screening are still needed. The importance of classifying pH patient to guide treatment choice, which are aimed to achieve a lowest risk profile possible. Survival has improved but remain lower for scleroderma, highlighting the need for continued research into the best treatment approach. From that, I would like to thank you for your attention.
Thank you so much, Dr. Siham. Please join us. So it's my great pleasure to introduce the next speaker, Dr. Imran Niazami. So Dr. Imran is a consultant. He is the section head of the lung transplant section of King Faisal Hospital and Research Center in Riyadh, Saudi Arabia. Dr. Imran will be speaking to us about timing for lung transplantation, a critical decision. Dr. Imran, welcome, and the floor is yours.
Assalamu alaikum, and thank you for inviting me. Let me just see if I know how to use this device. Oops. I was given this difficult task of talking about the timing of the lung transplant, which really is a very critical decision and a very, very difficult decision. Those of us that are involved in the transplant business know how challenging it can be. So I will try to walk you through the process which leads us to decide about listing and then eventually transplanting these patients with pulmonary hypertension. So Society of Heart-Lung Transplant has given us some guidelines, and their guidelines say, regardless of the disease, whether it's interstitial lung disease or COPD or cystic fibrosis, if you suspect that the patient has more than 50% risk of death from the underlying disease within the next 2 years, if the transplant is not performed, then you proceed with the transplantation. And the reason for this is that the transplant is not offered for quality of life purposes. The lung transplant is still offered as a survival advantage. The reason being, lung transplant is a high-risk surgery, and it has its own morbidity or mortality. At the same time, the guidelines tell us that the patient should have a likelihood of surviving at least 90 days after the lung transplant. And this is what we call as the transplant window. The patient should be really sick, that if we don't transplant, they will die, but at the same time, they should be healthy enough that they are capable of tolerating this extensive surgery of lung transplantation. At the same time, they should have a high likelihood of 5-year post-transplant survival, which is determined by presence or absence of other organ dysfunctions. So keeping that in mind, how do we predict about our PAH patients, whether they will have a risk of death in the next 2 years? Well, the life was much easier for lung transplant pulmonologists back in late 80s when we had the lung transplant started, because at that time we had no medications. We knew if we have a patient with pulmonary arterial hypertension, And as soon as they develop New York 3 dyspnea, they will die. So if we have pulmonary hypertension diagnosis, that was alone enough for us to put them on the list and transplant them. So if we look at the historical survival, the median survival for PAH was only 2.8 years, with 1, 3, and 5-year survival being 68, 48, and 34%. But then came epoprostenol, and after epoprostenol therapy alone, and after that there are many, many more medications, we realized that the survival of these patients has significantly improved. So we could not just use the diagnosis of pulmonary hypertension and New York 3 dyspnea as the reason to list those patients for lung transplantation. And in addition to that, making our life more difficult, the PAH, as we heard in the previous day or so, is a heterogeneous disease. It's not just one single disease, and one single formula cannot be applied to all the patients. So let me show you this slide, which is the group 1 pulmonary hypertension. We heard from the speaker earlier that in patients with congenital heart disease, if they develop Eisenmenger syndrome, they have a tenfold increase in mortality compared to the patients that did not have the heart defect fixed. However, if we compare different groups of PAH patients, the congenital heart disease patients is still, we call them as Energizer bunnies. I mean, they look blue and, you know, their fingers are clubbed, but they keep going and going and going. I mean, they can live for a very, very long time despite their underlying disease and severe hypoxemia. And I'm not sure how to show the pointer, but the bottom green line as well as the yellow line is the collagen vascular disease, which we heard from our previous speaker, are the patients that have worse survival if they have developed pulmonary hypertension, and PAH idiopathic somewhere in between. So if we see a patient with pulmonary hypertension in our clinic for lung transplantation, we cannot again apply the same formula to all these heterogeneous group of patients. We have to look at their underlying disease and keep that in consideration also. We heard a lot about the 6-minute walk test, and we know that this is a very useful tool in determining the outcome or the survival of the patients with pulmonary hypertension. But again, this was a South American study, and they challenged this 6-minute walk test. And they said, well, is the 6-minute walk distance of less than 250 meters less than 165 meters is still predictor, or less than 250 meters is the predictor of survival for their patients. And what they noticed is in their patient, if they used even 250 meters, it also predicted a very poor outcome. So there can be some very geographical differences, and I would strongly encourage that we look at this tool in our patient population. We know that our patient population, even in the healthy individual, have low exercise endurance. So maybe we are using a much higher number of 6-minute walk distance in our patient population to determine which patients are sicker and which patient needs the transplant. Maybe we should target at a much lower 6-minute walk test, because our surgeons always keep complaining that we get referral very late for the patients with pulmonary hypertension when they have much more advanced disease. So the cutoff of 165 meters may not be applicable to our patient's population. The New York Heart Classification dyspnea has always been a strong predictor and still is a strong predictor of mortality in patients with idiopathic and other forms of PAH. So if the patients still have New York 3 or New York 4 dyspnea, despite the maximum medical therapy, these patients can still be, these patients should be referred, because they will have a high mortality in the next 2 years. A little bit about bilirubin and the pulmonary arterial hypertension. Liver dysfunction actually reflects the status of the right heart failure. Why? Because when the right heart fails, there is passive congestion of the liver, which leads to elevated liver enzymes, including the bilirubin. In addition, when the right heart fails, the cardiac output drops. And when the cardiac output drops, the liver gets less perfusion. So there was a study that was published in 2010, and they looked at 37 patients with pulmonary arterial hypertension, and 12 of them died due to heart failure. What they noticed is that hyperbilirubinemia had the worst functional class, and also had the highest right atrial pressure as well as plasma concentration of pro-BNP. And the right ventricle failure parameters were all very high in patients with high bilirubin. So in this study, they showed us that the patients with high bilirubin, more than 1.2 compared to the patients with a normal bilirubin, had a very high mortality rate, and most of them die within the next year and a half. Now, this slide I always like to show because when I will show you the criteria for referring the patients and listing the patients for lung transplant, you will not see anywhere the mention of the pulmonary artery pressure. As we can see in this slide, that the pulmonary artery pressure keeps going. When it goes up and the pulmonary vascular resistance goes up, eventually the right heart starts failing. And when the right heart starts failing, actually the PA pressures will start coming down. So that's why when we look at the guidelines as to when to refer a patient for pulmonary hypertension for lung transplant, we will not see mentioning of pulmonary pressures anywhere. It will be mentioning of the parameters that show us how well compensated the right ventricle is. So this is just a slide to make us think in that the PA pressure alone don't mean anything. We have to look at the other parameters like right atrial pressure and cardiac output. So this slide we have seen many times before, and we have concentrated on the green part of it, but now I think it's time to concentrate on the right part of it, the red part of it. So the red signal is where the patients are going to be at a very high risk of death if they have pulmonary arterial hypertension, if they have clinical signs of right heart failure, if their progression of symptoms is very rapid, if they're having repeated syncopal episodes, if their WHO class is 4, and their 6-minute walk distance is less than 165. We don't usually do cardiopulmonary exercise testing. However, pro-BNP of more than 300 and right atrial pressure area of greater than 26 centimeter and the right atrial pressure of 14 are all the criteria that makes us that lead to very high mortality within the next 1 year for these patients. So putting all these things together, the Society of Heart-Lung Transplant has recommended times of referral as well as time of listing for these patients for lung transplant. For the time of referral, if they have New York Heart Dyspnea Class 3, if they have rapidly progressive disease, we all have encountered some patients that don't follow the usual pathway. Some of them will remain very stable on treatment, while the others will have a very rapidly progressive disease. And if you have to start these patients on parenteral targeted therapy, regardless of the symptoms, this is the time to refer those patients for lung transplant, not necessarily to list them or to transplant them. And also we know that pulmonary veno-occlusive disease does not respond to pulmonary vasodilator therapy. Therefore, these patients should be referred for lung transplant once the diagnosis is entertained. Now, as far as the timing of listing, if they remain in New York 3 or 4, despite a trial of at least 3 months of combination therapy, including prostanoids, or if their cardiac index is less than 2, their mean right atrial pressure is more than 15, and the 6-minute walk distance of less than 350. Also, if they develop significant hemoptysis or pericardial effusion or signs of progressive right heart failure in the form of renal dysfunction or increasing bilirubin or increasing pro-BNP, these patients can get listed for lung transplant. What we normally do is once we get a referral from the transplant, from the pulmonary hypertension group, as soon as they start them on the parenteral prostanoids, we do our assessment, and most of the time we reassess them in about 2 to 3 months to see how they are responding to the medical therapy. In the meantime, we do sometimes start the workup depending on how sick they are, and if they don't respond to the parenteral therapy, then we go ahead and put those patients on the list. But the life is still not that easy for us. And I will show you why. I mean, this was a Spanish study that looked at their patients that had pulmonary arterial hypertension and those who died and those who underwent lung transplantation. So the next slide will be a little bit busy, and I'll try to walk you through it. What they found in their registry that they had 1,391 patients with pulmonary arterial hypertension, and out of those, only 72%, which is in the bottom, were potential candidates for lung transplant. Most of them were not. And the ones that were not, interestingly, a lot of them were older age patients. And now we also know that the pulmonary hypertension is no longer a young individual's disease. You will be seeing more and more older patients. And most of the transplant members shy away from transplanting these patients if they're older than 60 years of age. And the reason being that these patients, all of them will require ECMO as a bridge to recovery after the transplant, because they will have significant primary graft dysfunction. They also have significant RV dysfunction, and therefore, at least for 2-3 days, they require the support of ECMO. So if they're older and they have pulmonary hypertension, most of the lung transplant team members will try to shy away from it. So I'm afraid that the pool of patients that are older will continue to have this disadvantage. In addition, a large number of the patients in this study were obese, and therefore I will strongly encourage that when you see your patients, you start counseling them on weight loss, because that will make them non-eligible for transplant. But what was more interesting to me in this study was in the bottom, they had 72 patients that were eligible for transplant, and only 36 of them underwent transplant. So half of the patients with pulmonary hypertension, despite being referred to the lung transplant center, don't get the lung transplant done. And that tells us that there is we still have some lack of understanding on how and when to list and transplant these patients. So I will talk a little bit about the lung allocation score. The lung allocation score is what we use in our lung transplant list patients. And that calculates the waitlist survival probability during the next year, and it also calculates the waitlist urgency measures. It also calculates the post-transplant survival probability during the first post-transplant year, and calculate the post-transplant survival measures. So this LAS score is now in use in North America and most of the other countries. There was a question that was raised in the Society of Heart-Lung Transplant by the pulmonary hypertension experts, whether this current lung allocation score effectively discriminate between those patients that most in need for transplant and those who can wait. But when they looked at the data, they realized that the answer was no. And why is that? Because the pulmonary hypertension patients appear much healthier on the outside, but they are actually very, very sick from inside. So to challenge that, we use this exception for the patients with pulmonary arterial hypertension. The exception is granted if they have a right atrial pressure of more than 15, or if their bilirubin is high, or if their creatinine is high, and if their 6-minute walk distance is less than 300 and declined by more than 100 meters. So these patients are then given an exception and moved higher up on the list so they can get transplanted. But still, despite all that, like I showed you in the Spanish study, only 50% of the patients with pulmonary hypertension that should undergo transplant are undergoing transplant in different centers. So to summarize this, the timing for lung transplant for PAH is a moving target. It requires not only the application of the general guidelines, but as well as the individual assessment of each patient. There are some patients that will have a rapidly progressive disease, and therefore those patients are dealt differently. We have heterogeneous nature of the disease, like the scleroderma patients with pulmonary hypertension have much worse prognosis, so therefore they probably should be considered a little bit differently. I showed you the 6-minute walk can be different geographically, and therefore there can be other geographical differences that we need to look at to see whether we are referring the patients in time for this pulmonary hypertension. And despite the best of our knowledge and best of our efforts, we noticed in the one of the Spanish studies that only 50% of the patients that are eligible undergo or do not undergo lung transplantation. And with this, I would like to stop and thank you for your.
Thank you very much, Dr. Nizami. Please have a seat here. Now, the floor is open for questions. Yes, please. If you can press the button on the top. Yeah.
Okay. Thank you very much for the excellent presentations. I want to ask Dr. Ragad regarding the increasing number of post-COVID interstitial lung disease. We didn't talk about the early cases of ground glass and like that. We talk about the settled cases already, what we have to do with these cases. Thank you very much.
Okay, thank you so much for your question. So the question regarding post-COVID interstitial lung disease. So again, I'm not an ILD expert, and I'm a pulmonary hypertension expert, but my say in this, if this is a concern about the interstitial lung disease post-COVID, so now I think there is studies has been done for almost a year or two, observational studies on the effective treatment, including steroid and some of the antifibrotic agent. So in terms of the pulmonary hypertension, we haven't seen yet increased prevalence of pulmonary hypertension related to COVID, whether related, not even related to COVID-related Saph or COVID-related interstitial lung disease. Maybe not yet, but we haven't seen yet increased prevalence of the pulmonary hypertension, if that is the question. In terms of the interstitial lung disease, yes, we have seen increased prevalence of interstitial lung disease. However, it's not the IBF interstitial lung disease. It's different form of interstitial lung disease, likely organizing pneumonia pattern, where these patients might actually respond better to steroid and some antifibrotic agent. Thank you so much.
Thank you, the chairpersons. I truly enjoyed this morning's session. All talks are amazingly high level, and they all have also, when we put this session, we wanted to put this heterogeneous, clinically oriented challenges from real day practice that we see normally in our clinics. So I have really many questions, but I will focus on the last speaker, Imran. You know, when we referred our patient to you for lung transplant, we feel in the pulmonary hypertension group that we probably refer them late. And the reason is many patients, I don't know, but it's probably cultural issue. They refuse to have the IV prostanoids as a way of treating them, although they are very late when it comes to the clinical status of these patients. So having the IV prostanoids as one indication for the lung transplant before listing them may not be very applicable to our group of patients, because we know that we have already started them late. And remember, we have a few patients who, unfortunately died in the list because we started them late, and then, of course, the transplant was not available immediately, obviously, and they died. So what's your take on this? How can, do you think we should modify the indication or the timing for the lung transplant for our patients, putting this in consideration? Thank you.
Yeah, thank you, Abdullah. And you always challenge me with these type of questions, even in the hospital. You know, we have looked at the cultural issues for other diseases, so I'm thinking, why not for this? And let me give you some example. In the West, we would never transplant somebody with a BMI of 14. We would always force them to get a gastrostomy tube, build their nutritional status. But in this part of the world, getting a gastrostomy tube is like, you know, is like a taboo. They refuse. So we have lowered our threshold of BMI from 18 all the way down to 14, just to accommodate the cultural setup for this for this part of the world. So your point of whether we should, you know, a lot of them may not like to use the pump, for example, and may not be tolerable for them, and should we, I think that's that's an option that we can discuss in our lung transplant committee meeting. As long as they're on 3 agents, and not necessarily the third agent is a parenteral agent, we can still entertain this possibility in individual patients. But having said that, the pulmonary hypertension patients are the most difficult patients to transplant, especially in the peri-operative period. So we also always try to find an excuse of not transplanting these patients. But I will put your thoughts to the committee and see what we can do.
Thank you. I just wanted to make a small comment. I think the issue of the advanced pulmonary hypertension patient, the patient who's manifesting RV dysfunction, is a very difficult one, right? The decision to give parenteral therapy is difficult. The decision to list is even more difficult. And I think the access in our setup, we don't have transplant. I mean, we just lost our lung transplant surgeon. We have another 6 months until the new one comes. So at this point, conceptually, we're thinking as soon as we start patients on parenteral therapy based on RV dysfunction, we are now going to start putting these patients in a prospective list and examine this issue of the exemption, just like they do in liver transplantation. For patients with portal pulmonary hypertension, really it has to be more clear in our protocol. So this is definitely something we lack in the UAE, and I think working with your group, because you have a lot of experience, and that would be very helpful.
Yeah, and just a supplementary question to Dr. Dalal. Some of these patients who were referred to you, they have a hugely dilated right ventricle, and this may not have a reverse remodeling after lung transplant. So is there any cutoff where you say this patient needs heart or lung rather than just the lung?
Well, actually, if you look at the international data, they said as long as there is any right ventricular function, even if it's 10% ejection fraction or something, we don't give them heart and lung transplant. And even if we present them to heart and lung transplant committee, the heart people will refuse because they will say, why you want to waste a heart? As long as there's left ventricle is working, the RV should remodel. The problem happens is immediately post-transplant period, the RV will not immediately remodel. So these patients will require to be on an ECMO support, VA ECMO support as a bridge to recovery. And the worse the right ventricle is before they go into the surgery, the longer time it will take. And that again brings me to the point that we always shy away from these patients if they're older than 60 years of age, which is going to be, I think, increasing population in the future. Because of this fact that post-transplant, we are afraid that they will need to be on ECMO for a very long time. So no, there is no cutoff of RV as long as, unless there is another congenital heart defect present, which we cannot fix, a large VSD or a large ASD, we don't give them heart-lung transplant.
Okay, next question, please.
I just have a question along these lines. Is there any role of cardiac MRI to detect any fibrosis in the RV before deciding on heart, lung, or lung-only transplant?
Sorry, I did not understand that.
So my question is there
cardiac
any role of cardiac MRI for
risk stratification? Is that right?
For late gadolinium enhanced? So if the RV is fibrosed, then you probably think more towards a heart-lung. If there's no evidence of fibrosis, then the chances of remodeling are greater, and then you just go with lung. So is there any role for cardiac MRI?
No, not to my knowledge. The only time we do cardiac MRI is actually to look at the other congenital defects that may not have been visible on the transesophageal echocardiogram, but not for the RV remodeling purposes.
Next, please.
Yeah, assalamu alaikum. So this is Waleed Hafiz. I'm a rheumatologist from Mecca and interested in scleroderma. Thank you, dear speakers, for this very informative and diverse meeting, and also thank you for hosting rheumatology in this meeting. So my question is, how do you see pulmonary arterial hypertension in systemic sclerosis compared to other connective tissue diseases? We in rheumatology think that pulmonary arterial hypertension in systemic sclerosis is way difficult and more severe when it's compared to other diseases. The response that we get in other diseases with immunosuppressive medications is much better than when it comes to pulmonary arterial hypertension. We've also been learning that there are different, clinical phenotypes in pulmonary arterial hypertension that is associated with systemic sclerosis, and the fact that pH in systemic sclerosis is of diverse heterogeneity, so it's not only confined to group 1 hypertension. Are we still lacking the role of antifibrotics in these particular patients?
Okay, Dr. Hafid, regarding scleroderma patient, as you know that it is very heterogeneous, and it involves multiple, cytokines, immune dysregulation, fibrosis, not like other connective tissue disease, where the immune suppression did work on these patients, and even as I showed before, that the survival is better. Again, for the scleroderma, they have multiple involvement. I mean that interstitial lung disease is more, cardiac fibrosis is more, so it is a diffuse process in comparing to other connective tissue disease, where they have maybe only group 1, or they might have group 4 like CTIF and lupus, or they have group 3 when they have cardiomyopathy or interstitial lung disease in 2 and 3 and so on. But I think scleroderma patient is not yet targeted, i.e. there is still room to target other defect in the immune dysregulation. Even the immune suppressive therapy, they tried everything you can name it. Even the scleroderma lung study, they tried the CellCept for lung fibrosis and comparing to the cyclophosphamide. They tried the azathioprine and so on. So again, for scleroderma patient, you see the trend of renal cell crisis decrease, and the risk of steroid in scleroderma, as you are aware, is risky to give them high dose steroid. Many treatment was offered and searched for the scleroderma patient, but it unfortunately did not work. The reason why maybe still some defect or in the immune dysregulation is not targeted. As I showed that even the RV dysfunction is very characteristic in scleroderma patients. They respond, but at the end they fail. And the right and the left ventricle in the MRI for scleroderma patient again showed diminished perfusion, which is again a characteristic in scleroderma. So in the future, maybe it will answer your question.
Yeah, the thing is that most of the studies that were conducted in interstitial lung disease, either with immunosuppressive or antifibrotics, they excluded all patients who had pulmonary arterial hypertension. So we do not yet have any study that tested antifibrotics in pulmonary arterial hypertension. I think this is the time where we can conduct some studies that can assess the impact of antifibrotics in patients with PAH secondary to systemic sclerosis. Thank you.
Thank you very much for your comment. Next question, please. Okay. Yeah, whoever is first. Thank you.
Thank you. David Jenkins, Cambridge, UK. It was a really interesting discussion about lung transplant.
We can't hear you. If you can use the mic, please.
David Jenkins, UK.
No, it is on, but just be close to the mic, please.
It was a really interesting discussion about timing of lung transplantation in PAH, and two short comments really. One, I think we're seeing fewer patients coming for transplantation in PAH because of better drug therapy, and I take the point about IV therapy as a threshold for listing with better triple oral therapies, and I think that is developing. And the other important reason for that, the improved survival with drug therapy, is actually the survival after lung transplantation is still not that great, with even in the best centers, the other window of transplantation we could consider is 60% median survival after bilateral lung transplantation, even in some of the best centers. So there's the window after transplantation as well, and that's the real thing that makes the timing of listing so important. And the other comment is about the operation. They are some of the hardest patients to get through lung transplantation, and the post-operative period, as we heard, can be very difficult. Not all will need VA ECMO support, but in some of the most severe cases they do, and it's not because of the RV failing. One CBR drops after bilateral lung transplantation, the terrible RVs will always go, but it's to retrain the LV because the LV is being used to very low cardiac output and is very compressed, and often the VA ECMO is needed the first week to prevent pulmonary edema as the LV gets used to the greater volume, and that's the real reason the VA ECMO is needed in some of these patients. Thank you very much.
Thank you very much for your comments. Thank you. Yeah, next question, please.
Thank you. So back to rheumatology again. It was a great presentation. Thanks for that. It's basically a comment, maybe even a question, if you don't mind. Now, we know that the DETECT study has a benchmark change in rheumatology and bridge our relation with our interventional cardiologists. We're very lucky sitting in a room full of people, very enthusiastic, willing to work with PH, but let's remember, in some other centers, it's very hard to convince the interventional cardiologist to put a cath and get an RHC done. So DETECT has changed our relations with our colleagues. Now let's remember that the mass number of pulmonary hypertension and DETECT is 4% compared to the ERS, which is 29%. My input on DETECT is that still we need to work harder on it because we need to detect really early stages of NIHA 1 and 2 to refer them earlier. So a few points that will be very interesting to our rheumatologists in the room. I mean, things that we need to work on. One of the points or the scoring system in DETECT that just ANA. We all know that ANA by itself is not a good biomarker. The different antibodies that are related to scleroderma, each of them has a different strength, especially with pH. And then the other thing is that also the near-field capillaroscopy, I know that you all are doing it right now, but how much of that we can interpret it in the DETECT score. So that's just ideas to be shared if you are all interested. Thanks.
Thank you very much. Thank you. Yes, please.
Again, from a rheumatology point of view, Samar Al-Amadi, Qatar. So it's a comment, actually, it's not a question. I think for systemic sclerosis, we are not supposed to look at it as a one disease. We need to look at it as a multiple diseases in a one patient, giving the heterogeneity of the pathogenesis that's happening. And currently, there are a lot of new cytokines that the basic science are trying to target in systemic sclerosis. And maybe this is going to be the future for us because till today, with all the advances in rheumatology, with all the biologics that we are using, with all the small molecules, till today we don't have a single target to target systemic sclerosis. So what we are doing is just targeting the complication of the disease. So I think we need to look at it as a heterogeneous, multiple diseases in one patient. Thank you.
Thank you very much. The last question from the middle, please.
Thank you. I am Dr. Assam Sabri from Pulmonary Hypertension Unit in Kuwait. In the previous classifications, starting a few decades back, there was clinical group 1. In the clinical group 1, pulmonary arterial hypertension associated, there was connective tissue disease associated. In the latest classification, there was pulmonary veno-occlusive disease. Previously, it was mentioned as a one entity, pulmonary veno-occlusive disease, but in the latest classification, there is subdivision of it. It became now recognized as that's heritable and connective tissue disease associated. So patients with systemic sclerosis now, or a scleroderma spectrum of the disease, can have two presentations, one as a clinical group 1 and one as pulmonary veno-occlusive disease. There is any data which is showing the prevalence of the pulmonary veno-occlusive disease in the scleroderma or systemic sclerosis spectrum of the disease? Because we know that idiopathic pulmonary hypertension is a well-recognized in systemic sclerosis spectrum of the disease. But about pulmonary veno-occlusive disease?
Okay, I think...
Thank you very much. Thank you.
Thank you so much. I think it is difficult to determine veno-occlusive disease in scleroderma without looking into that. But there are some few clues. So, for example, patient may worse when starting the pH-targeted therapy. This is a clue. Or if you are looking for other causes for pulmonary hypertension in general, when you do your CT scan and you see this ground glass appearance and hilar lymphadenopathy in pH. So this is the things that can differentiate and help. The prevalence of BVOD disease in scleroderma, I didn't come across that. So I cannot tell you, to be honest.
Thank you very much. Regarding the suspicious of pulmonary veno-occlusive disease from pulmonary hypertension point of view, the onset of symptoms, the rapidity of its development, the response to specific therapy, the development of pulmonary congestion, all this, of course, is well known. But there is no studies recently which addressed the prevalence of the pulmonary venous occlusive disease, because to be in the new classification, of course, there is a data which support this classification. This is the exact point I was asking about.
Thank you so much, Dr. Sam. Okay. We will conclude the session now. There will be coffee break, and we will meet again at 11 o'clock. Thank you.
Hear me now? Okay, beautiful. Good morning, everyone. I'm Dr. Badr Zahrani. I'm an interventional cardiologist at Prince Sultan Cardiac Center. This next session is going to be about CTEF. I just want to thank the organizing committee and Saph for the kind invitation. It's really, I'm pleased and honored to be here. This is Dr. Manal Hazmi. She's going to co-chair this session. It's about CTEF. I want to introduce our first speaker, Dr. Majdi Idris, who's the former president of the Saudi Association for Pulmonary Hypertension. He's an adjunct professor of pulmonary medicine at the British Columbia University. He's really a close friend, and I learned from him a lot. The stage is all yours, Dr. Majdi, for CTEF.
Assalamu alaikum wa rahmatullah. Thank you, Mr. Chairman, for the nice introduction. I would like to thank the organizing committee for giving me the privilege to be with you here today. So we're going to talk about CTEF, and we're going to start with this introductory lecture talking about the current understanding of the basically biology about CTEF per se. So this is my disclaimer. So as we all know that basically CTEF now is characterized or really basically classified as group 4 according to the WHO pH classification. And our understanding in general is that the situation starts by an acute, basically clotting, acute pulmonary embolism, and for some reason that clot failed to resolve. And then there will be progressive fibrosis, more obstruction, and the development of basically what we call now chronic thromboembolic pulmonary hypertension. So, but if you basically take a step backward, I'm sure that is that what happens always? And the answer is probably no, because we know that up to 30 to 40% of those patients who came with CTEF, they had no previous history of VTE. And some of them, when they present with the acute attack, or so-called acute attack, and we do the initial echo, their pressure is in their 60s, 70s, or 80s, probably indicating that this is not an acute PE, this is actually prevalent CTEF with an acute and chronic presentation. And we know from data that up to 50% of the patient after acute pulmonary embolism, they fail to have basically complete normalization of their VQ scanning. Despite that, only the minority of them will develop chronic thromboembolic pulmonary hypertension for a very complex reason that we're going to talk about basically in a second. But as we believe now that about anything between 0.5 up to 4 to 5% of the patient after acute pulmonary embolism might end with chronic thromboembolic pulmonary hypertension. And we know that there is basically multiple risk factors for that that's been documented now in the literature, including the presence of past history of malignancy, thyroid replacement treatment, probably because of the activation of the platelets, the presence of lupus anticoagulant, basically blood group other than O group, go figure why that's happening. Basically recurrent VTE, severe or massive pulmonary embolism, and of course splenectomy and basically infected pacemaker or atrial ventricular shunting. And the current understanding when you look at basically CTEF is that there is a clotting problems, a chronic clotting problem in the pulmonary vasculature, goes to the either proximal, intermediate, or distal vessel. But our visual, if you like, basically understanding of really CTEF, that it is simply chronic process that keep really progressing distally. Although this is true, but I'll try today to just change that in a bit to tell you that this is not the whole story. It's far more complex than that. So the way we understand CTEF at the moment is that there is a clotting problem that happens in some of those patients, And because of really multiple factors, including basically thrombogenic, basically stimuli, inflammation, probably infection, genetic basically susceptibility in some patient, that lead to, yes, we do have in those patients basically chronic obstruction, but the situation is more than that, and you have what we call small vessel disease, and we have right heart basically pictured that is work with the CTEPH pathophysiology. Now, let's talk initially about this thrombosis and what happened with those patients. Now, we know that the usual or the standard thrombogenic basically diseases such as basic antithrombin 3 deficiencies, protein C, protein S, factor 5 laden mutation, etc., are not that common in CTEPH. So they are not the usual predisposing factor. However, we know that those patients who have CTEPH, they are more likely to have antiphospholipid antibodies. They are more likely to have increased level of factor 8 and increased level of basically von Willebrand factor, which is a molecule that is very important to basically stabilize and regulate the function of factor 8. And also we have data to show that a special molecule called the ADAM TS13, now, or the other name for that is basically von Willebrand factor cleavage molecules. Now that molecule is important in, again, orchestrating the function of that basically von Willebrand factor. Having low level of that molecule is a common cause for TTP, for example, very thrombogenic event. And there is data to show that what happened in CTEPH patient, we have down-regulation of that active pathway. So basically, those patients do have basically a reason, a genetic reason for really clotting. Now, another important molecule that's called basically platelets endothelial adhesion molecules. And this molecule is very important in basically orchestrating the inflammatory process after the acute clotting, which is very, very important, basically a result that will help in the thrombus resolution. So we know that the soluble form of that molecule is again overexpressed in those patients with the CTEPH. We have from data that, for example, patients who have basically the post-thrombotic syndrome, they are more likely to have a much higher level of the PCAM, the soluble form of the PCAM. And those who have major thrombotic load, again, they have much higher level, basically, of that molecule. And finally, when we talk about really that basically thrombosis, we know that the fibrin molecule itself that is formed in CTEPH patient, it is actually mutated at different chains. And those fibrins are more resistant to the lysis compared to normal fibrin. So the message here that there is a genuine thrombotic diseases when it comes to CTEPH patient. What about inflammation? And inflammation is another basically field of great interest in the field. And we know that if you take the really basically sample after the, let's say, endarterectomy and look at that sample, surgical sample, you would find a lot of inflammatory cells going from the macrophage, neutrophil, and the lymphocyte. And it seems that depends on the type of that clotting mechanism, the really incidence or the likelihood to have more exaggerated inflammatory response there. It's more common in the basically atherosclerotic and the thrombotic and clotting. And these inflammatory cells, actually some of them, such as the B lymphocyte, go very distal, while other inflammatory cells work on the transmural, the whole thickness, basically, of the blood vessels. And many inflammatory markers have been overexpressed in CTEPH patient. And we know, for example, if you look at some of them, for example, the really monocyte basically chemotactic, basically protein, it does correlate as well with the hemodynamics. So the higher the level of this inflammatory mediator might lead to more severe clinical disease. There is similar data that's shown with the IL-6 and the IL-10. So it seems that these inflammatory really mediators are very important when it comes to that. Now, infection is a new kind of very interesting basically mechanism that might affect the lysis of the clot. And in this study, they look at about basically 7 samples came from really infected pacemaker wiring. And they found that 6 out of those 7, they were actually infected with the staph. About 5 were Staph aureus, 1 was basically Staph epidermidis. And when they look at that, was that just only really causation or association? It seemed that the bacteria, especially Staph bacteria, can basically slow down the resolution of the clot, as shown that those patients who had very positive basically DNA of the bacteria in that clot, they were more likely to have basically collagen deposition, and they were more likely to be associated with increase in the basically transforming growth factor beta, again suggesting that the bacteria itself has a role in that. Now let's shift gears to the different part really of the story, the vascular component. And we know that really the classical understanding is that you have a clot there, that basically the green one there. So that can cause an obstructive, basically pulmonary hypertension, if you like. And then people start looking at then what happened to the cardiac output. Most of the cardiac output will go to the non-occluded part. And now so that's going to be increased flow, very similar to the congenital heart disease that we heard from Dr. Hani Sabur earlier today. So once that happens, there is really increased flow, so there's more shear stress, there's more basically endothelial cell deformity, very, very similar to what happened with the congenital heart disease, pulmonary arterial hypertension, and that might as well ended in really plexiform lesion, very similar to what happened in really group 1 in those non-obstructed vessels. But again, the story does not stop there, because those actually even obstructed vessels, they do show the same basically pathobiology, including basically the cell deformity, really remodeling process, the vasculopathy that can happen in patient with PAH-like pictures. So those people can actually develop that. And when you ask why, these are obstructed vessels, and the distal vessels are not exposed to increased cardiac output. However, what we learn that the pre-existent anastomosis between the bronchial artery and the pulmonary artery, because when you occlude the vessels, the pressure in that occluded vessel distally goes down, so there will be some really gradient between bronchial artery and the pulmonary artery, so there'll be re-anastomosing at the level of the pre-capillaries, giving you very similar to PAH, capillary, that give you very similar to the basically capillary hemangiomatoses, and post-capillary to the PVOD. So again, the process is far more than simple clotting of the pulmonary vessels. This slide is very common when you talk about pulmonary arterial hypertension. However, I can tell you that there is a really escalation or upregulation of this pathway as well, again adding to the small vessel disease in those patients. We have data to show that if you look at the ADMA, which is a molecule that's supposed to really inhibit the nitric oxide synthetase, so really block the whole active pathway of the nitric oxide in those patients, nitric oxide, soluble guanylate cyclase, and cyclic GMP is also activated in CTEPH patient. And we know that those patients who have much higher level of this molecule, the ADMA, they have worse outcome. And maybe that's tell you why riociguat work in those patients, because riociguat work on this pathway. And probably that's not a nocebo effect, that's a true effect that happened with riociguat in those patients. Also, data show that the endothelin pathway is also activated in those patients, causing the same problem, very similar, really, pathobiology compared to basically pulmonary arterial hypertension. So really the end result is, yes, there's an obstructive load there, but there's a lot of vasculopathy that happen really distally. And the way to pick that up actually clinically is basically to look at what we call the percentage of the vascular obstruction, basically in those patients, looking at the VQ scanning and come with the end of that. So what happened, which is very different than basically what happened in patient with acute pulmonary embolism, that there is a good basically correlation between the obstructed load and at the PVR. You can see that some of those patients with a CTEPH, they have very low obstruction load, but they still have very high PVR, indicating that the problem is not simply with the really proximal obstruction, but it goes very, very distally in those patients. So clinically, the end result is really having right ventricular failure and RV basically maladaptation. And whenever that happens, those patients actually die. So in conclusion, ladies and gentlemen, I think I told you here today that there is a correlation between the clotting, acute clotting, and the chronic, basically thromboembolic that can happen in those patients. We believe that there is some association, but it's not always basically clear. We know that some of those patients, the minority of them, will move in that direction, probably in those who have genetic susceptibility, they have blood thrombosis, active inflammation, and that leads to the impairment of the thrombus resolution and impaired angiogenesis. And at the end of the day, the final result that you will have that really triad of chronic obstruction, small vessel disease, and at the end, RV remodeling and RV failure. And with that, I would like to thank you very much for your attention.
Professor Majdi. We'll leave the question till the end. Now we welcome Dr. Hazza Zahrani, consultant hematologist from King Faisal Specialist Hospital and Research Center. He will talk to us about the role of extrapulmonary hematobiosis in CTEPH, in myeloproliferative disease. Dr. Hazza, the floor is yours.
Assalamu alaikum. Good morning. It's a great pleasure and honor to be with you today. And I really thank the organizers for inviting me to present on the topic of pulmonary hypertension in patients with myeloproliferative disorders. I have nothing special to disclose in relation to the content of this presentation. This is the outline of my presentation. I'll give a brief introduction on myeloproliferative disorders. Then we'll talk about the prevalence of pulmonary hypertension and myeloproliferative diseases, pathogenesis, diagnosis, and treatment. So as you know, myeloproliferative disorders are acquired hematopoietic disorders that are characterized by uncontrolled overproduction of hematopoietic stem cells that leads to overproduction of mature red cells, platelets, and white cells. And this may be complicated by several issues, including extramedullary hematopoiesis in the liver, the lung, the lymph nodes, and the spleen, myelofibrosis, and acute myeloid leukemia. The WHO in 2008 and 16 classified myeloproliferative disorders into Philadelphia positive and Philadelphia negative myeloproliferative disorders. And the three categories of polycythemia vera, essential thrombocythemia, and primary myelofibrosis are at particularly high risk of development of pulmonary hypertension. Going back to medicine level, you know very well that CML is caused by translocation between chromosome 9 and 22, leading to BCR-ABL translocation that can be detected by irregular karyotype, FISH, or PCR. And CML has three phases: chronic phase, accelerated phase, and blast crisis. We treat most of the patients with tyrosine kinase inhibitors, and we rarely nowadays use allogenic stem cell transplantation except in cases of accelerated phase and blast crisis. These are the types of Philadelphia negative myeloproliferative disorders, and we'll focus on myelofibrosis, P. vera, and of the hematopoietic stem cells. This is the prevalence of different molecular anomalies in these patients, and basically JAK2 mutations present in almost all polycythemia vera patients, 60% of ET and around 55% of primary myelofibrosis. CALR is less common, and MPL is also less common. And MPN leads to a multitude of symptoms, but I think the most important, most worrisome symptom is, in the short term at least, is the development of thrombotic complications that is caused by changes in platelets, coagulation, cytokines, endothelium, and white cells, with a final common pathway of increased risk of thrombosis that can be detected in up to 45% of patients. And these diseases have some features that may overlap with each other, and also as time goes by, some patients who present initially with CET or polycythemia may transform to myelofibrosis or AML. Now moving to the pulmonary hypertension in these patients, in chronic myeloid leukemia, it is mainly medication related, and specifically mostly with dasatinib. And in this study from Korea, they looked at 280 patients. 60 of them had symptoms that may indicate pulmonary hypertension. Those 60, only 49 of them had echocardiogram, which showed pulmonary hypertension being a high probability. So out of all the patients, 3.5% had pulmonary hypertension. And in these patients, the disease was reversible with discontinuation of these medications. And another study here that showed the different risk with different medications, showing the highest risk being in dasatinib. And there are many other risk factors inherent to the patient, including the advanced age and the presence of cardiopulmonary symptoms. I think this is one of the best sources to indicate to us the risk of pulmonary hypertension in CML patients, in particular in relation to dasatinib. This is the large study where they compared the dasatinib to imatinib as a frontline therapy, and they did a long-term follow-up of hundreds of patients. And in that study, 5% of patients treated with dasatinib had pulmonary hypertension compared to 0.4% in those who received imatinib. In other myeloproliferative disorders, pulmonary hypertension is classified as class 5 with other hematological disorders. And the prevalence varies from one report to another. Multiple spawn reports have been reported. The variation in the prevalence of pulmonary hypertension in these patients depends on the subtypes of diseases in these reports, and also on the way the pulmonary hypertension was diagnosed. So if the echo was diagnosed, you will tend to have an overdiagnosis, and if a right heart cath was used, this may be significantly lower. This is a study by Alberto and a group from Italy, basically looking at, they did a meta-analysis on the prevalence of risk factor of pulmonary hypertension associated with chronic myeloproliferative disorders. So they had 221 reports, and after selection, finally end up with 17 studies. These are listed here, showing the ways they used to diagnose pulmonary hypertension. Only 4 studies or reports showed that they used right heart cath. And then they classified the patients and compared the two groups, basically. And this graph shows you the prevalence in different studies. So overall, you can have as high risk as 58 and as low as 3%. And basically, the pooled prevalence was thought to be 28.8%. And this variation is due to the extreme high variability between the studies itself, and also the specific factors like the way they diagnose the disease, and also the subtypes of the disease, the age of the patient, and other comorbidities. Now, what are the proposed mechanisms for pulmonary hypertension in these disorders? One is the thrombocytosis, which leads to activation of platelets and secretion of platelet-derived growth factors and serotonin. As mentioned earlier, the chronic thromboembolic pulmonary hypertension. Portal hypertension is also seen because of the massively enlarged liver and spleen in these patients with excessive blood flow to these organs. High output state, veno-occlusive disease in a situation like patients treated with anagrelide, which we commonly use to reduce the platelet count. and also the aberrant JAK2 and SRC signal transduction and a transcription pathway, which promotes inflammation and leads to abnormal proliferative state and enhance abnormal angiogenesis and depletes the nitric oxide and leads to pulmonary vascular remodeling. This is an animal study from Japan where they transplanted mice by JAK2 marrow cells that from a JAK2 mutated knock-in mice. And you can see in the upper graph, the wall thickness was higher in those who had JAK2 mutation under the hypoxic situation. And in the lower left graph here, you see that the elastase activity is much more increased in the JAK2 mutant mice. And you see the wall thickness under the electron microscopy was also significantly more obvious in the JAK2 mutated mice. And in addition, the pulmonary pressures were significantly higher in the mice which had the JAK2 mutants. So they concluded that clonal hematopoiesis with JAK2 mutation causally leads to pulmonary hypertension development in association with ALK1 upregulation. And they also showed that a JAK1 and JAK2 inhibitor, momelotinib, completely prevents the pulmonary hypertension in these mice. Also, the high hematocrit leads to slow blood flow on the venous side, and also on the arterial side, it leads to some disruption of the laminar flow, pushing platelets outside the central part of the blood vessels, and this leads to activation of platelets and being proximal to the endothelium, causing more likelihood of activation of these platelets with the release of thromboxane and platelet-derived growth factors and vascular endothelial growth factors, and ultimately thrombosis. We mentioned pulmonary hypertension. This is a spleen of one of my patients who underwent splenectomy 2 weeks ago. So that can also predispose to the very high blood flow and to portopulmonary syndrome. The splenectomy are the, and you are experts here, where is shown to be higher in patients with, there is a higher chance of finding history of splenectomy in patients with CTIF and pulmonary hypertension. And the international prospective CTIF registry showed 3.4% of patients had history of splenectomy. And the post-splenectomy red cells and platelet microparticles may contribute to arteriopathy and distal and proximal thromboembolic sequelae. We mentioned the portopulmonary syndrome. This is rarely used now as a treatment for pulmonary hypertension, for myeloproliferative disorders, but these are medications that, if used, may also increase the risk of pulmonary hypertension and worsen the pulmonary complications in these patients. Last part is the extramedullary hematopoiesis, which may complicate myeloproliferative disorders, and this can be in the portal circulation causing portal hypertension or in the pulmonary vessels. Tumor emboli or circulating megakaryocytes with subsequent release of vasoactive substances may also increase the vessel tone and increase the pressure in the pulmonary vascular bed. This is a patient that I share her care with Dr. Abdullah Dalan. She's a 44-year-old lady with polycythemia rubra vera, chronic thromboembolic pulmonary hypertension, history of Cadasel syndrome and epilepsy. She has classic features of polycythemia rubra vera with markedly hypercellular marrow. And she had imaging studies through using technetium sulfur colloid scan, and you see the lungs are massively infiltrated by the hematopoietic cells, and they are especially the right lung is as densely infiltrated by the hematopoietic cells as the liver and the spleen. The patient was seen recently. She was treated with 1 session of radiation therapy to the whole lung, but she also received some specific pulmonary hypertension therapies. And in her last follow-up, she says that she has and improvement in their daily activities. So in primary myelofibrosis, pulmonary hypertension presents with progressive dyspnea and signs of ventricular heart failure and rapidly increasing liver and spleen size, and these patients die very soon if untreated. This is a report from the literature showing, again, similar picture to our patient with technetium sulfur colloid in a scan showing the activity in the lung, and also when they fuse the SPECT with CT, very obviously you see diffuse uptake corresponding to the findings in the planar imaging. Another case that you see here, the ground glass opacification on the coronal CT scan, and the biopsies show you see erythroid precursors, myeloid precursors, and megakaryocytic precursors in the left lower figure, and a similar picture here, but the image staining here for the vessels showing excessive number of blood vessel formation at the alveolar level. A similar picture here with diffuse interlobal septal thickening caused by extramedullary hematopoiesis. This is a recent report of extramedullary hematopoiesis presenting with pulmonary hypertension. In a single case, you see the right pulmonary artery is filled with extramedullary mass. When on biopsy, you see on the left lower side immature hematopoietic cells that are infiltrating the pulmonary artery vessel. And here they reviewed the cases where patients had different outcome, but using extended radiation therapy, around 50% of these patients had remarkable improvement of their pulmonary hypertension. Now, treatment will, of course, depend on treating the underlying disease, and this can be done using cytoreductive therapy like hydroxyurea, which may improve the pulmonary hypertension, but unlikely to totally resolve it. Allogenic stem cell transplant has been shown to reverse pulmonary hypertension in patients with myelofibrosis. JAK2 inhibitors, also the drug that is used now, is ruxolitinib, and it has been reported in 15 patients to improve the right ventricular pressure and also improve the pro-brain natriuretic peptide and nitric oxide level. But there are limited data on the pulmonary specific pulmonary hypertension therapies for these patients. This is the long-term survival of patients with myeloproliferative disorders who have extramedullary hematopoiesis or pulmonary hypertension, sorry. And you see that there is a marked difference in the survival, especially in those who have polycythemia vera in the right upper corner. And overall, there is lower or poorer survival in these patients. Now, in drug-induced pulmonary hypertension caused by dasatinib, simply you evaluate by echo, and if there is clear evidence of pulmonary hypertension, you move to further evaluation by right heart cath. And if the patient is considered high risk, then you treat immediately with specific therapies for pulmonary hypertension that you know better than anyone else. Now, for patients with pulmonary hypertension in primary myelofibrosis...
Just 1 minute, please.
Yes, sir. I'm done. You evaluate the occult pulmonary extramedullary hematopoiesis. You exclude post-thrombotic pulmonary hypertension, and you treat the current with the current management lines of pulmonary hypertension. And as we said, single fraction or even some reports used up to 200 centigrades of external beam radiation therapy for palliating pulmonary to the lung to palliate the extramedullary hematopoiesis. And in this report, they had shown improvement in the performance status and pulmonary artery pressure and on the imaging studies of the extramedullary hematopoiesis. So several plausible pathophysiological mechanisms make the MPN patients are at higher risk of pulmonary hypertension, and this includes hyperviscosity, platelet activation, thrombosis, splenectomy, portal hypertension, and pulmonary infiltration. I think hematologists should be actively screening for clinical and objective features of pulmonary hypertension in these patients, Pulmonologists should also be vigilant to features of myoproliferative neoplasm in patients who are referred to them with pulmonary hypertension, and extramedullary hematopoiesis-induced pulmonary hypertension can improve dramatically after external radiation therapy. And thank you very much for your attention.
Thank you so much, Dr. Hazzaf, for your excellent presentation. For the sake of time, we're going to leave the questions to the end of the session. I want to introduce the next speaker, Professor Nick Kim, who's going to talk about medical therapy in chronic thromboembolic pulmonary hypertension. Professor Kim is the director of the Pulmonary Vascular Medicine program at UC San Diego. He's the medical director of the Pulmonary Thromboenderectomy program at UC San Diego. I had the honor to work with Professor Kim in UC San Diego when I was a fellow. Unfortunately, he's not here, but we have a full recorded lecture for him. So let's go.
Or studies have been done internationally on the field of CTEPH and medical therapy, and I chose these 3 articles going back to the AIR study with iloprost published in 2002. Remember, the inoperable CTEPH patients were lumped together with other forms of secondary pulmonary arterial hypertension. Overall, that group did not respond as well as the idiopathic group, but it was really the first sign that maybe pH-targeted therapy could benefit these patients. The second study was the benefit study with bosentan. This was a study that I was involved with post-hoc adjudication process, and I think we learned a lot from the study, including the challenges of adequate imaging. It did show some conflicting results in terms of hemodynamic improvement, but no changes in the 6-minute walk distance. And it really paved the way, I think, for future studies. We learned a lot from that. And then finally, we have the CHEST-1 study with riociguat, which was really the breakthrough that we needed in this field. I compiled this table here. It's a bit of a busy table, but just to highlight some of the key lessons from these trials. From the CHEST-1, this led to the first regulatory approval of riociguat for inoperable CTEPH. We, for the first time, had a prospective adjudication process with expert surgeons. We also learned at the time even the imaging was improved. Dr. Jenkins nicely in the adjudication group pointed out that almost 1 out of 5 of those patients actually that local providers felt was inoperable was felt to be operable by the central group. And with this potent therapy, we saw separation in 6-minute walk as early as 8 weeks. We also saw that the treatment effect was driven by therapy rather than decline in the placebo group. And thankfully, in the long-term extension, there was some catch-up noticed. I want to show you some exciting recent data. This was presented by our colleague Marianne Decroix at the ERS meeting. This is based on additional analyses from the new CTEPH registry from the ICA that was published by Stefan Guth earlier last year. And this is showing the Kaplan-Meier survival of these over 1,000 consecutive cases enrolled from, I believe, about 19 countries around the world. And you see the survival with endarterectomy was best at 93% at 3 years. Very close was BPA, 87%. Medical therapy, unfortunately, did far worse, 69%. When you divide up the medical treatment group with riociguat, which obviously was approved based on the CHEST-1 trial and other studies since then, this is why we do the clinical trials that we do, because we want to make sure we identify effective therapies that can give benefit for these patients. Now, these lower bar are patients who were either on no therapy in yellow or on other pH-targeted therapy compared to, let's say, riociguat. So I think you're going to hear some more exciting, detailed analysis of such a registry. This is a real-world experience, obviously, but it's nice to know that if you follow the treatment algorithms that we all propose, you can actually have excellent outcomes for your patients. But what about combination treatment modality? I know this is a topic that's probably of keen interest for all of you who do also pulmonary arterial hypertension therapy. If we go back to the last guidelines in 2015, which I understand will shortly be updated, we really don't see any comments about combination medical therapy, at least in the CTAF population, but I suspect that's going to change shortly. And some of that's based on the studies that I'm going to talk about in the rest of the slide. So this was the MERIT-1 study with macitentan 10 milligram. This is a phase 2 trial looking at just inoperable patients compared to background therapy. So nearly 2/3 of these patients were on background, most commonly PD-5 inhibitor. And you saw that the treatment arm with macitentan and the primary endpoint of PVR reduction had a significant effect even over the placebo group, and the subgroup analyses favored macitentan treatment. And if you look at the secondary endpoint at 24 weeks and 6-minute walk distance, again, one of the lessons we learned from the earlier benefit trial is to look at the 6-minute walk perhaps a little later, and this was intentionally designed into this trial based on that. You saw a nice separation out at 24 weeks. This is not a registration trial. We're currently undergoing a worldwide study in the higher dose macitentan, which I'll talk about in the coming slides. So let's add that to that table. So the MERIT-1, it was the first trial that showed that combination therapy may benefit our patients. However, this trial had some limitations in that it excluded post-endarterectomy patients. It continued the prospective adjudication process, which is very important since we all believe surgery is still the treatment of choice in most of these patients. It had a small sample size. The primary endpoint of PVR, we learned that these right heart caths need to be closely adjudicated. And I think the major drawback of this trial, or the limitation, is that it didn't include patients on riociguat or balloon pulmonary angioplasty, both therapies which obviously are very important now in the treatment of CTAF. This next trial, published a few years ago, introduced subcutaneous treprostinil for patients with inoperable disease. This was a nice study conducted led by my colleague Irene Lang, who showed that higher dose treprostinil subcu up to about 30 nanogram per kilogram per minute led to better results than 3 nanogram per kilogram per minute in the low dose arm. And you saw a 40-meter walk distance improvement at their analysis point. This was, as far as I'm aware, it did include heterogeneous groups of CTAF patients, including patients who, for whatever the reason, were not deemed reasonable for surgery, but it did offer a potential for a new additional therapy that's approved in some parts of the world, particularly in Europe. More recently, we saw this report from our Japanese colleagues on selexipag for inoperable CTAF. By the way, in the CTREF study, about 30% of them were on background, so we do have some data with combination with treprostinil. Here you see about 2/3 of the patients were actually on background therapy as well, so we're going to have more and more data, I think, on combination therapy. And you see when they compared the selexipag arm from the placebo arm, again, 2/3 of them already on approved pH therapies. You saw a further reduction in pulmonary vascular resistance in selexipag, and this has led to approval for selexipag in Japan for inoperable CTAF. If you look at that study closer, I think you'll notice that there wasn't a significant change in 6-minute walk distance, so we are seeing some mixed signals here. And we're seeing that still with, I think, some of our current efforts with the SELECT study, which has been halted. This was a study looking at selexipag in patients with either inoperable or patients after intervention, such as endarterectomy or BPA. And the interim analysis led to a cessation of that study, and I think we'll learn more about some of the reasons in coming meetings. The MASITEF study is the study that I referred to earlier. This is a global study looking at high-dose 75 milligram macitentan, which has some theoretical advantages in RV function. And so that's being studied with both inoperable and patients with persistent pulmonary hypertension after one of the interventions. So I highly encourage you to try to work with centers who are involved in this study to get us some patients for that study. Lastly, I want to just remind ourselves of this very exciting study that's being spearheaded by our colleagues in Paris. This is the IMPACT CTEPH trial. That's the center that provided the RACE study results, which were really instructive in terms of balloon pulmonary angioplasty versus first-line medical therapy. But what they're looking at here is whether first-line combination medical therapy versus riociguat therapy will have any difference. These are patients who are deemed to be non-operable candidates who eventually will go on to balloon pulmonary angioplasty, but mainly asking the question, is two therapy up front better than single therapy? So I think we're all looking forward to this study. So in terms of the future, I just wanted to share with you a little perspective on pulmonary arterial hypertension, and this was published in the last World Symposium from our PAH colleagues looking at the evolution of PAH approvals and the different trials going from left to right. Remember PAH, the first treatment was heart-lung transplant out of Stanford in 1982, and then the first medical therapy, epoprostenol, at least in the FDA, was 1995. And we've had other therapies along the way, but in red, we're looking at combination strategies as well as blue as well with upfront combination. So this is kind of the evolution, if you will, starting with single therapy all the way to potentially combination strategies. But I think we learned in pulmonary arterial hypertension, it's combination done the right way. For example, early combination and not waiting for clear failure before combination by using things like risk assessment and being proactive. I'll finish with this kind of cartoon that I've shown in other meetings about where we are in terms of strategies and targeting CTEPH treatment. The right ventricle, larger vessels on the left side down to the capillary bed. We recognize this is really a multimodal disease, where the first treatment we need to consider is relieving the mechanical obstruction, ideally with pulmonary endarterectomy, but in cases that are not candidates for that, pulmonary angioplasty, and I think you'll hear a nice discussion about that from the next speakers. But the focus of this talk was really recognizing the small vessel disease also is a problem, as well as the right ventricle. And so we need to continue some studies and investigations into how to best optimize and target the microvasculature here with medical therapies or combination strategies. So in conclusion, just want to point out that microvascular disease does contribute to PH in these patients. The current approved therapies include riociguat, which are found or approved in most parts of the world, and subcutaneous treprostinil in select centers in countries in Europe, as well as now selexipag in Japan. In terms of combination PH therapy in CTEPH, I think the data is growing, and it may just be a matter of time. We will see. But finally, just a reminder, pH-targeted medical therapy should not be the first step in treating CTEPH. It's really one aspect of a multidimensional condition, and the treatment decisions really ought to start with operability assessment with a careful multidisciplinary review. Thank you very much.
Thank you very much, Professor Kim. You finished earlier, 10 minutes earlier, so we can entertain a couple of questions before the next speaker get ready for their session.
I have a question to Dr. Majdi. What do you think the role of the systemic to pulmonary circulation or shunting in the obstructed segments and its role in the development of the microvasculopathy? Can we target that circular or shunting to try to prevent the development of CTEPH in the future? Thank you.
Dr. Abdullah. Can you repeat the question, please, because we couldn't hear it very well.
Sorry. So I'm just wondering about the role of the systemic to pulmonary shunting in the obstructed segments in the PAs after PEs and its role in the development of the microvasculopathy. Could this be a potential target for preventing CTEPH?
That's definitely fascinating, basically question. And here the question is regarding those vessels that they are distal to the obstructive, basically pathway. We believe that dropping the pressure in those vessels will create some basically gradients, so really enhance the systemic to really pulmonary circulation. And I think this is definitely why we believe that when we say that patients who have basically proximal disease should go for either surgical intervention or balloon angioplasty early enough before the development of the small vessel disease. And this is why all basically literature say that once you make a diagnosis of CTEPH and you believe that those patients are surgically candidate or at least balloon angioplasty candidate, those patients should be subjected to the treatment without delay, because it seems that the more you delay, the more you're going to allow this basically systemic pulmonary circulation to really evolve, and then development of the small vessel disease. Because as you know that once you establish the small vessel disease situation, then those patients are less candidate to go for surgery, even less candidate to go for the balloon angioplasty, and the outcome become worse. So I think the strategy that we're doing at the moment to prevent that is to really recognize those patients early and intervene early before the situation develop. Now, having targeted therapy to those, I think definitely we have now riociguat basically work really very clearly in those patients, and other medication, as we heard from Dr. Kem, that they do work in those patients who have quite distal small vessel disease. I hope I answered your question. Thank you.
Dr. Abdullah, tfadal.
Dr. Hazza, thank you so much for your talk. And I think people are wondering why what the hematologist is doing in a pulmonary hypertension meeting. But I think you made the message very clear. I think myeloproliferative disorder, especially JAK2 mutation and complications that we can see in general pulmonary clinic clearly as actually as you clearly showed. The extrapulmonary, the extramedullary hematopoiesis is an essential role in the mechanism of developing the pulmonary hypertension, but also, of course, with the thrombogenic complications that can lead to CTEPH. I think you and I we have discussed this several times, but I want people to know what is the role for such an aggressive disease, role of bone marrow transplant or stem cell transplant in these patients, and what's your experience with this? Would this lead to complete resolution of the pulmonary hypertension / CTEPH or what? I just want people to know your experience in this.
Thank you, Dr. Abdullah, and it's an honor to be with the colleagues here in pulmonary field. So the indication for stem cell transplant is only for patients who develop or evolve to acute leukemia. Or those who have myelofibrosis and are younger and have overall general good conditions. So, and they have appropriate donor, and basically matched related donor, or we rarely use haploidentical or matched unrelated donor. So the role of transplant has been reported to improve the pulmonary hypertension in patients with myelofibrosis. So this is the only category of myeloproliferative disorders where we use stem cell transplant for them. And in our hospital, we do actively transplant these patients. I don't remember anyone who had an initial pulmonary hypertension as part of their
pre-transplant workup, but only in the literature, anecdotal cases of pulmonary hypertension as a complication of myelofibrosis improved after transplant.
Dr. Hazza, I just have a question. In terms of anticoagulation in myeloproliferative disorders in CTEPH patients, would you rather go with low molecular or NOACs, or what would you recommend?
Thank you very much. These patients are at higher risk of liver disorders, as you know, because of risk of bad Chiari, varices, and many of them present at the initial presentation with visceral thrombosis. So in general, we use, in our practice, we use DOACs and low molecular heparin as appropriate, like general population. If there is antiphospholipid, we prefer to use warfarin, of course. And if the patient has more advanced liver disease, child POO, B or C, we avoid rivaroxaban. In earlier liver disease, we can use apixaban. Low molecular heparin is very useful and very helpful and easy to administer and adjust the dose according to the patient's clinical manifestation. But it is very painful to patients and very problematic. So I prefer using DOACs except antiphospholipid.
So it's time. Final question. Yes, okay. Dr. Ahmed.
Yeah, thank you. Thank you, all speakers. My question to Dr. Majdi, you showed us very beautifully that in the pathophysiology of the CTEPH, it's not only the thromboembolic issues. It's something to go with the autoregulation of other pathways as well. So why we still the nomenclature is chronic thromboembolic, and if that's the case, do you suggest that because I know that the CTEPH is from 6 months to almost to 24 months after the first episode of pulmonary embolism. So do you suggest that we need to go ahead and to give anticoagulation for extended period, like two years or so? Thank you.
Well, thank you so much. So a little bit of complex question. So why CTEPH? Why we call it chronic thromboembolic? I was not involved in the World Congress naming, so that's really beyond me. But I think we know that really the process really starts as really clotting, and then the clotting continues. So there is really chronic thromboembolic really mechanism. I think, I agree with you, that this name is kind of understating the true nature of the disease. And now we know more that what's happening, and I think now there is some changes even in the really nomenclature that's going to be addressed to the previously called CTEPH, So that's going to change with time, as now there is really evaluation for that. Now, should we prolong the really anticoagulation in those patients? I think it depends. If you have those patients who are at risk for having CTEPH, those, for example, who have splenectomy, those who have basically infected, basically pacemaker wiring, those patients who have antiphospholipid, those patients we do kind of treat them a bit differently, and we really screen them for a longer period of time. Those patients who have a simple acute pulmonary embolism with low risk factor, if they, according to the guideline, they have really major risk for really PE, we treat them for 3 months and then we stop. But definitely those patients who have at risk, maybe we should really continue anticoagulation for a longer period of time and really monitor them, because as you said, up to 2 years, they can develop CTEPH in those patients.
Dr. Abdullah? Just a quick comment in line of this. Ahmed, this is a very good question. In fact, there is now emerging evidence. I think this name will be changed soon in the probably coming guidelines. It is now called chronic thromboembolic pulmonary disease with or without pulmonary hypertension. So it's already in the literature now, and I think this is going to take place in the coming guidelines.
Time now for the next session. And it's about the CTEF management, first intervention, whether it's pulmonary endarterectomy as first intervention or balloon angioplasty. It was expected to be a debate, pros and cons debate, but we apologize for that Professor Irene, she could not join, and now we welcome Professor David Jenkins. He's a cardiothoracic surgeon, director of UK Pulmonary Endarterectomy Program, and he's the lead surgeon for the National Pulmonary Endarterectomy. Professor Jenkins, the floor is yours.
Thank you very much. Good afternoon, ladies and gentlemen. Thank you to the organizers for inviting me. It's going to be a relatively unusual debate because I heard 2 minutes before I started that the person I'm debating against not only couldn't get here, but couldn't connect either. So I'm going to celebrate early. I think I've already won the debate. But I will try and cover what Irene Lang, who's a friend and colleague, would have said about balloon pulmonary angioplasty. So these are my disclosures. I've got no conflict of interest with respect to this presentation, apart from obviously the fact that I'm a surgeon and I'm the only debater. So I was asked to give the reasons to consider pulmonary endarterectomy as the first treatment for CTEF. And I think this is probably an easier task, and perhaps that's why Irene has not come to contend her part. And I should point out that there are no randomized controlled trials of first intervention with surgery or BPA. So there's no high quality evidence. So this is very much expert opinion. And I'm going to hope to convince you with 6 main reasons why I consider pulmonary endarterectomy should be the first treatment for CTEF. And after these 6 reasons, I'll try to show you the evidence why I believe these. So the first and most important ones is the ability to remove all the disease, to potentially cure the patient. And I would contend that for many patients with CTEF, surgery is probably the only treatment needed, so it certainly should be first. It also gives you the ability to treat the most widespread area of the pulmonary artery with all types of disease, from small distal webs to proximal laminated thrombus, and actually most levels of disease as well. I would contend that my 1 millimeter surgical forceps can go as far distally as Irene Lang's 1 millimeter balloons. It's also a one-stop treatment with an instant reduction in PA pressure and PVR, so you get the immediate benefit of the hemodynamics. And there's a long history of experience using this operation, more than double the time that BPA has been around, and far more patients treated with pulmonary endarterectomy than with balloon angioplasty. And that the risk profile in experienced centers is now very reliable with low in-hospital mortality and very good longer-term survival. It's the most evidence for sustained improvement in symptoms, function, quality of life. Again, no randomized trials, but from large case series and large registries that I will show you. And finally, of course, all the guidelines suggest that pulmonary endarterectomy should be the first treatment for CTEF, and for good reason, as I will demonstrate. So we've seen this picture already, but it's important to understand. This is a cartoon of the left pulmonary artery from the pulmonary valve down to the microcirculation. As my friend Nick Kim explained, for the microcirculation, we need drug therapy. But the majority of CTEF is a mechanical problem in the macrocirculation, and therefore the interventional treatments are very important. This is a cartoon of the area of the pulmonary artery that could be treated by pulmonary endarterectomy and by balloon angioplasty. Importantly, you'll see there's quite an overlap there, and I think in experienced centers it is true that the surgeons and interventionists can operate on the same vessels in the subsegmental branches and the segmental branches. But I'd like to point out, as my area of the debate, that the area of surgery treatment is probably double the area of balloon treatment. So there is much more scope for surgery and pulmonary endarterectomy in CTEPH. And in order to convince you that the surgeons can actually remove the disease rather than just compressing it against the wall, and can operate as distally as people with balloon angioplasty, I've got a short video to show you distal endarterectomy in action. Now, normally this surgery takes 6 to 8 hours because we have to cool down the patient and have deep hypothermic circulatory arrest. But I've just condensed it. Don't worry, it's not going to be a 6-hour movie. We've condensed it just to a few minutes to show you the highlights. So this is a patient with relatively distal disease. This is an MRI pulmonary angiogram showing the right and left pulmonary arteries in the exact patient we're going to be operating on. This is looking in the right pulmonary artery initially without the circ arrest, showing that there's blood in the way, so you don't get a good view. But you can see there, as we look into segmental branches and subsegmental branches, this is with the circulation arrested. You can see, and as you get down into the subsegments, you can see the white thickening and start of webs. This is after the surgical clearance. You can see we've actually removed all the disease going down into subsegmental vessels. So the branches are completely clear at the end of a good distal endarterectomy. And then this is looking on the left side, again without the circulation arrest. You can see the blood in the way. You can see the thickened endothelium with some plaques due to the high pressure. This is looking into an upper lobe, into an apical segment, and this is a small distal web at subsegmental level. This is looking at the same patient's imaging to show where we're looking at on the CT. So we're down in the subsegmental branches. And this is filmed with a 5mm flexible 4K camera looking into the left pulmonary artery with the circulation arrested, into the upper lobe, apical segment, and subsegmental branches. And then this is removal of that web with a 1mm forceps. And looking again now right up there, seeing 4 tiny branches going off after the web is removed. And this is the specimen from that patient, showing that this is the little web you saw from that apical segment just there, and showing that the disease here is very distal, but can be removed by surgery. So I would contend that unlike BPA, we can actually remove the disease and we can get as distal as the balloon pulmonary angioplasty cardiologists. These are some pictures from my colleague in San Diego, from Michael Madani, and this is really to illustrate the scope of pulmonary endarterectomy. You can see that we can remove proximal laminated thrombus and obstructed distal tails, segmental, lobar and segmental disease, and subsegmental disease. And because of the advance of surgery into more distal areas by the experienced surgeons, there is a new classification now of the levels of disease, with 4 levels of disease, and that's classified at the time of the operation when looking at the disease. But this is really to illustrate that with surgery, we can go from this all the way down to this. Whereas Irene may be very good at dealing with the distal webs, but cannot deal with these other parts of the CTEPH. And in most patients, there is a mixture of anatomical disease throughout the whole pulmonary tree. So now coming on to the effectiveness of surgery compared with BPA. And we get an immediate upfront result with surgery. This is a series of patients from my own center, from Papworth. And what we did is we divided our patients from right at the start of the series to just before the COVID pandemic into 4 quartiles, each with over 500 patients in, and looked at the immediate hemodynamics pre-bypass and immediately post-bypass and the in-hospital results. And this is really to illustrate, if we concentrate on the percentage decrease in mean PA pressure, you can see that it's up to, in our most recent cohort, over 50% immediate reduction in mean PA pressure pre-bypass compared with post-bypass after surgery. And for PVR, it's almost a reduction of 2/3, over 60% reduction. So unlike BPA, where multiple treatments may be required, with surgery, it's a one-stop shop, and we get an immediate improvement in hemodynamic results. And also, I'd like to point out here that although it's massive surgery, in experienced centers now, the 30-day mortality is less than 2%. So it's not as serious an intervention as some people would suggest. And then going on to survival, I was charitable. I've just shown the first registry from the ICA Worldwide Registry showing the 3-year survival. And the surgical patients who had pulmonary endarterectomy are in red. This era predates balloon pulmonary angioplasty. The non-treated patients are in blue. And you can see a 3-year survival approaching 90% for surgery. In our most recent ICA, the second international registry, as Nick Kim demonstrated, the survival has improved further. The full paper hasn't been published yet, but the survival has improved further to 92% for surgery. And that registry includes patients having balloon pulmonary angioplasty. But those patients do reasonably well, but by 3 years, only 88% are still alive. So there's non-significant, but there's a trend to improved survival with surgery compared with BPA. And then finally, what's important to patients is their activity, quality of life, and symptoms. And this again is Royal Papworth Hospital data, looking at CAMP4, which is a dedicated pH quality of life score. And Irene would say that there is evidence for BPA to improve quality of life and symptoms, but it's not as great an improvement as we get with surgery. Here we can see low is better. Here we can see a massive improvement in activity, in quality of life factors, and in general symptoms after surgery. And this, importantly, this improvement is sustained out to 5 years. So it's not a temporary improvement. It is a really dramatic improvement that's sustained for 5 years. And finally, coming on to the guidelines, what do the guidelines say about BPA and pulmonary endarterectomy surgery? Well, Irene would say that these guidelines I'm showing here are old guidelines, and she's right. These predate the development of BPA in Europe. These are from 2016, 2015. And what they said was that surgery using deep hypothermic circulatory arrest is recommended for patients with CTEPH. It's only a 1C because there's never been a randomized trial, but it is a strong indication for surgery at that stage. And Irene would be right to say there wasn't BPA in Europe or America at that time, so that's why it doesn't figure. But then we go on to the 6th World Symposium, which is 2018. Now, BPA was around at that time, but we still concluded that pulmonary endarterectomy should be the treatment of choice. So in 2018, with all the experts evaluating all the evidence, we concluded that pulmonary endarterectomy should be the treatment of choice. We did mention BPA along with targeted medical therapy because at that stage there was the positive randomized controlled trial, but the treatment of choice we concluded was pulmonary endarterectomy. And then moving on to the latest consensus statements, guidelines, the ERS statement on CTEPH published just last year. So now we're up to date and we've got BPA included in this statement. But we said when we gave the conclusions of this statement that there's likely to be considerable overlap anatomically between BPA and pulmonary endarterectomy, but we emphasized that segmental and subsegmental disease are suitable for surgery in expert centers. So the surgeons can treat almost as distal as the cardiologists. And we also said that it's inoperable CTEPH patients can benefit from BPA. So it's very important to realize that the first treatment should be pulmonary endarterectomy, and it's only inoperable patients should be considered for balloon pulmonary angioplasty. And that optimal CTEPH treatment requires a multidisciplinary team that can look at all three treatments for these patients: medical therapy, balloon angioplasty, and pulmonary endarterectomy. And we also mentioned that there may be a role of BPA as a bridging therapy prior to pulmonary endarterectomy in patients with mixed surgical accessible and inaccessible lesions. So some perhaps evidence for Irene that in a small number of cases there may be a role for BPA as the first treatment, but this is likely to be a very small number of patients. And finally then, the ISHLT, International Society of Heart-Lung Transplantation, consensus statement on CTEPH, published just last year again, and that said BPA, pulmonary endarterectomy under circulatory arrest is the standard of care for CTEPH. So again implying that pulmonary endarterectomy is the first treatment for patients with CTEPH. So I hope I've convinced you that in patients who are considered operable, who have PVR in proportion to the anatomical disease, surgery should be the first intervention. And that's what all the current guidelines and consensus statements agree on. I will agree that there are a small number of patients who have PVR out of proportion and have mixed anatomical disease where we're really not sure of the best treatment. And there are 4 potential options for this group of patients with a more mixed disease, higher PVR, more distal disease, where we would have doubts about surgery. We at Royal Papworth Hospital, and I'm sure colleagues at San Diego would argue that actually a higher risk pulmonary endarterectomy is still the best treatment, and accept some residual pulmonary hypertension and add pulmonary vasodilator drugs after surgery. So clear what's the obstructive disease first, and then we have randomized controlled trial evidence from CHEST 1 to justify adding pulmonary vasodilator drugs with riociguat after surgery for residual PH. And that would be our normal course of action in this patient group. There is increasing experience with drug pre-treatment, but lack of good randomized controlled trial evidence. Unfortunately, the riociguat bridging therapy trial had to be abandoned because of the COVID pandemic and poor recruitment. So we don't have good trial evidence, but there's increasing experience of adding drugs prior to surgery for patients with CTEPH who are operable but have high PVR, which is perhaps out of proportion. The other alternatives, which Irene would probably argue, is for hybrid treatments or BPA prior to surgery in order to try and reduce PVR and reduce the risk of surgery. So there are some small case series of hybrid treatments where pulmonary endarterectomy surgery is performed on one side and BPA on the other side. We don't have any experience of that, but there are some small case reports. And also, there is some experience of performing BPA prior to surgery as a planned treatment to reduce the PVR before surgery. But again, experience with that is very limited. So in conclusion, I would suggest that pulmonary endarterectomy is definitely the first-line treatment for CTEPH. In the UK, we have an expression, ladies first, but on this occasion, unfortunately, Irene, this is Irene here performing her first BPA in Japan when I was with her, and this is me performing pulmonary endarterectomy surgery. But I think on this occasion, it should be me going first with my knife, and she can follow with her balloon if there is any residual pH after surgery. I'd like to thank you very much for your attention.
Thank you so much for your excellent presentation. Although we didn't hear from Professor Irene about BPA, we're still going to have a debate about BPA and endarterectomy and discussion. We're open for any questions, please. Dr. Faiz,
yeah.
Go ahead.
Thank you, Dr. Jenkins, for the beautiful, brilliant presentation. So, as you know, the PPA has evolved actually significantly since 2004. And now actually in Japan, they dilating the proximal disease. So do you think in the future that PPA will replace the endarterectomy?
That's a good question. And as Irene isn't here, it's very good that you are here. I think probably it may go more proximally, but I don't think, for the reasons I've explained, it can replace. It can't really deal with major occlusion or at lobar level or massive laminated thrombus in the main pulmonary arteries. So yes, it may be very good at subsegmental webs and perhaps even segmental occlusions, but it would be very difficult to see it dealing with the sort of pictures of disease I showed you affecting main lobar and segmental occlusions.
So I have another question, if you don't mind. So what are the indications for endarterectomy in seated chronic thromboembolic disease?
So I presume you're talking about patients with chronic thromboembolic disease but without pulmonary hypertension at rest. We do operate on some of those patients, but they're carefully selected patients. The indication is improvement of symptoms, but those patients need very careful consent because the operation is a massive intervention, so it is a real balance of risk versus benefit. But the majority of patients with that condition that have wanted surgery are younger patients who perhaps used to be athletes, who then have a PE and develop chronic thromboembolic disease, and they're perhaps class 2, but they used to run marathons, they used to be very active, and they are very limited by their symptoms and want to get back to a better quality of life. And I think as long as the results of pulmonary endarterectomy are good with a low risk of complications, then it's reasonable to operate on a selected group of these patients as long as they understand what is involved.
Thank you.
Thank you.
Dr. Abdullah, go ahead.
Thank you very much for your excellent talk. So I'm a interventional cardiologist, and a common debate that we have on a weekly basis between us and the surgeon is PCI versus CABG. What's the evidence showing is that complete revascularization is probably what matters. So when we apply this to CTEPH, I know the comparison is not fair because, I mean, we have surgeons, very excellent surgeons like yourselves, and then we have less experienced surgeons. And at the same time, we have interventional cardiologists who are just looking for anything to balloon and dilate, and the learning curve for BPA, I would imagine, is probably less than that of PEA. So my question is, should it be, instead of PEA versus BPA, should it be which modality will give us, will remove more material or open more vessels, as opposed to making it between PA and BPA? Should we just start talking about how much are we going to remove by PEA, how much are we going to dilate by PPA, and then make a decision based on that? Thank you.
Thank you very much. I think that's a very interesting philosophy, and I would agree with. And I think you touched on the fact that there are different levels of experience with cardiologists and with surgeons. And I think around the world, there are some areas such as Japan where they have more experience of BPA and less experience of surgery. And therefore, for those patients, it may be BPA would be a better option. And there are other areas around the world where the reverse is true and there are very mature surgical programs. So I think you've got to, on the intervention side, for your patients, you've got to consider what the local experience is before making the decision. But you're right, in some ways, it's dependent on how much disease can be cleared by the interventionists, whether they're surgeons or cardiologists, in the region you're working in. And I also agree that there are real parallels with ischemic heart disease, a completely different disease, but the concept of surgical revascularization with CABG versus stenting and ballooning in ischemic heart disease is very similar to some of the arguments of surgery versus BPA for CTEPH disease, even including that some of the survival advantages of surgery don't become apparent until 2, 3, 5 years down the line, so that like lots of interventions, up to the first year, the patient's survival is actually better with a less invasive interventional treatment rather than the surgical treatment. But once you get to 2, 3, 4 years afterwards, the survival curves cross, and the longer term benefits are more apparent with the larger surgical intervention compared with the smaller intervention.
Just a comment about your question, Dr. Abdul. We believe in complete revascularization when it comes in terms of cardiology and ACS patients. The difference in terms of CTEPH patients, that the guidance is kind of a little bit different. You look at the hemodynamics, the symptoms of the patient, the need of oxygen, the 6-minute walk. So there's a lot of factors we look at. In terms of revascularization, we're kind of limited when it comes to BPA sessions. If the patient had, depends on how much contrast you gave, and usually we focus in 2 segments. We're limited by 300 cc's of contrast, and also there is a limitation in terms of radiation in the cath lab. And the downside by fixing even more is the reperfusion injury, of course. So that's the other thing that you have to look at. So it's kind of different than the cardiac perspective of it. Go ahead. There's another question.
There's one here.
Go ahead, Saph.
Thank you very much. Of course, when we are encountering a patient with CTEPH, we are doing thrombophilia screen at the etiology for the condition. Is the ongoing thrombophilia process, like patient with systemic LSE and antiphospholipid and lupus anticoagulant, may raise our concern about proceeding of the pulmonary endarterectomy because the pathologic process is ongoing, or we will do the pulmonary endarterectomy at the first line treatment for CTEPH, and we will go for the medical treatment for the underlying condition, regardless it is ongoing or not. I would like to know your opinion. Thank you very much.
Question, Dr. Majdi, or who? Dr. Jenkins?
For Dr. Majdi, yes.
I think the question here regarding if you have a patient with antiphospholipid syndrome,
yes,
and he is basically highly thrombogenic,
yes,
would you still go for surgery? I think the answer is yes, but I'll leave that to Dr. David.
Yes, we do, but we are aware that those patients have a much higher risk of recurrent CTEPH. And in our experience of only about nearly 2,500 pulmonary endarterectomies, we've only done less than 25 redo pulmonary endarterectomies. And about half of those are patients who've had their first surgery elsewhere overseas and perhaps not had a full clearance. But about half of them are our own patients that we operated on years previously, and they've had a true recurrent disease. And the majority of those tend to be younger females with antiphospholipid syndrome. So yes, we certainly operate on them, and the majority do very well, but that subgroup is probably more at risk of true recurrent thrombotic disease in the future compared with other patients with CTEPH.
Thank you very much.
I'll just say, but this is really a major problem because you know that the only drug that can be used for anticoagulation in those patients is warfarin.
Yes.
And we just had a patient who had basically a surgical procedure. She went home, actually significantly improved with her very, very severe disease. She was just admitted 2 weeks back with major clot in her superior vena cava and right, basically atrium. And definitely that was because of the inadequate anticoagulation with warfarin. This patient was not very much compliant. So I think antiphospholipid is really, I think the problem is not simply surgical, it's how to deal with really warfarin, with the high dose warfarin INR in those patients who can clot very, very frequently, like what happened in our patient, unfortunately.
This question is based on a real life story. I have a patient with SLE and antiphospholipid syndrome and positive lupus anticoagulant. She has a chronic thromboembolic pulmonary hypertension, so there was a debate to proceed or for pulmonary endoarterectomy, or because the underlying ongoing highly thrombophilic process, it will recur. Of course, we boarded it, and she did pulmonary endoarterectomy, and the pulmonary pressure normalized, and the pulmonary vascular resistance decreased. So this is why the cause I am asking about this. If there is any published data or any trials looking for this point, the rate of recurrence in this patient. Thank you very much.
Well taken point, thank you.
Thank you very much, for the last speakers, all the speakers actually. I mean, the surgery is fantastic. I used to work during my training in Papworth Hospital, and we used to do echo on patient after surgery, 2 days after surgery, and the dramatic improvement. Now, as the classical teaching in medicine, we usually use the non-invasive or less invasive procedure, and then we go for the invasive procedures, which is obviously not the case with the CTEF. Now, my question, do you have like a time to intervene for endarterectomy in patients with CTEF? Do you have like a guidelines when to do the surgery for them? Thank you.
This is Dr. David, right?
A question to Dr. Jenkins? Okay.
Yes, I think all the guidelines suggest that once CTEF is diagnosed, as long as the patient is symptomatic, then there's no reason to delay surgery. It is the recommended treatment. So if the patient's symptomatic enough and understands the risks and benefits and the evidence is in favor of surgery, there would be no reason to delay surgery. There are a few patients we have who perhaps have very mild pH, or they have disease without pH, who want to watch and wait, who perhaps have got other things going on with their lives, who don't want surgery at the time, and they're followed up carefully. A proportion of them will get worsening pulmonary hypertension and come on to have surgery. But intriguingly, there is a group of patients with quite extensive thrombotic chronic material on imaging who perhaps have very mild pH or no pH at all, who remain remarkably stable with class 2 symptoms for many years, who may never come to surgery. So it is a very interesting and complex disease that we don't fully understand.
I just
have a question. Go ahead.
Yeah, I just do have a comment as a stranger in the room, rheumatologist again. Regarding antiphospholipid, where I consider myself see a lot of antiphospholipid, you need to do a risk stratification for your patient. Not all the antibodies will give you the risk of a thrombogenic. So lupus anticoagulant is the highest risk of a thrombogenic association in comparison to the beta-2 glycoprotein and anticardiolipin, and then you will go with other risk like IgG is more higher than an IgM. The other things that those people, they have to be on lifelong anticoagulation. It is not like 3 months, 6 months, or 2 years. They have to be from day one with evidence of a thrombosis. They have to be on a lifelong anticoagulation. The other things that if they have a combination with the lupus, and we knew that immune suppression will help in the treatment of pulmonary hypertension, but if they don't have an association with an antiphospholipid, this is completely a different scenario. I do have a young lady who's a 15 and now she's like a 20 something. Every single day she's coming to the hospital either because of a bleeding or because of other medical condition. Her RFSBB is like more than 110. So she knows that she's gonna die. Nobody is doing anything, but we are maintaining her anticoagulation and the INR in the higher range. So you all the time you need to keep it like 3.5 up to 4, where it is not indicated in other antiphospholipid. Thank you.
I think the point is well taken, and this is the problem that really we face when those patients who really underwent major surgery, and then they do have antiphospholipid. That patient that I was talking about, she was very thrombogenic, having very, very basically frequent PE in the past. And now when she went home with almost close to normal hemodynamics. But now she came back with this big clot, and we were reviewing her really INR in the last really few weeks at home. Some of them was 1.3, 1.4. So this is really a reality that really faced. Although that patient, she was really told clearly that this is your life-saving medication now, the warfarin, but that can still happen. So unfortunate.
So keep the mic, Majdi. This question is to you. I know the good work you did for the last patient, and in line with what the last three speakers, questions were. Just me ask you a practical question. Now, these patients, suppose they have either PPA or pulmonary endarterectomy, but they have this very badly thrombogenic activity going on, whether it's myeloproliferative disorder or antiphospholipid syndrome. And you clearly illustrated in your talk how bad this small vessel disease can be. Now, how far you go with these patients? How far you go with medical treatment in terms of giving combination therapy, including IV parenteral prostanoids? And would you also redo, if they are technically okay, would you go for lung transplant for these patients? Can you just tell us what you should, how extensive your approach with these patients?
Okay, so I think when it comes to the matter of redo the surgery, that's definitely can be done. So that's not a problem from that particular aspect. Even lung transplantation could be really offered in really patient with really proper indication. I think here the problem that we face sometimes with some patient that they have some kind of, I will say, really personal immaturity issue. This patient had major previous trauma that her basically sister died with the same disease in the past. So this patient was really having some psychological issues. So now what we are doing, we are really involving the psychologists and really psychiatrists to tell us or really to guide us about what should we do next. Can we trust this patient in a way that should we just send her home on Clexane, for example, and she will be on Clexane for basically the rest of her life, if that's going to basically save her? Or can we trust her? But for example, she was telling me that her daughter was eating basically salad with a lot of greens. And she said, I like greens. So I told my daughter, I'll just share with you a little bit of that salad. Clearly, this patient was not very committed to her medication. So what should we do with her now? I think we need to reevaluate. We did talk to her now. The psychologists now are on board. But definitely, we will not be willing to go any further regarding surgery versus really lung transplant if we believe that psychologically she is not fit for that. And that every time she will go home with warfarin, she will take it 1-2 days, and then she is basically going to skip 2-3 days. I don't think that will be a real option with her.
But in general, not this particular patient, in general, these aggressive diseases, when they have this, good procedures done for them, and they continue to have problems, do you treat them like a PAH patient at the end of the day?
Right.
Or what do you do? What's your experience in this?
We do. We treat them basically exactly like PAH case. For example, this patient, if we believe that any patient that she has surgery and she still have really residual disease, so basically we treat them with start with basically riociguat, but now we have a patient on combination therapy, a riociguat and macitentan. So we do treat them as basically PH because I believe now we have enough data to say that those patients, they have multiple active signaling pathway, which is very similar to PAH group. So probably, yes, we go very, very aggressive with them. We go for 1 drug, 2 drugs, and we have 1 patient on 3 drugs. This patient came from San Diego, actually. She had persistent disease, and then now she's on 3 drugs. So that can happen. So this can happen, and we treat them as we are treating PAH patient, basically, indeed.
Thank you. In the immediate post-op period, I think it is very important to maintain these patients. I prefer low molecular weight heparin because, as you said, and we have shared a recent patient, we kept her on low molecular weight heparin, minimum 6 weeks, preferable 3 months. And in antiphospholipid patients, I think
it is very important to try to eradicate the root of the problem, which is basically utilization of disease-modifying agents. So adding hydroxychloroquine, statins, and in selected patients, rituximab, depending on the whole context of the clinical manifestation of the patient. We have, I was telling Prof. Jenkins that we have done auto-transplant for a series of very aggressive antiphospholipid antibody patients. So I'm not assuming, I'm suggesting this in the immediate post-transplant, but it just post-surgical period. I think eradicating and dealing with the antibodies and trying to get rid of it will help in prolonging the long-term outcome of these patients.
Can I make one comment? I agree with whatever's been said, and as the lady said before, it's often the triple positive patients are the really high-risk ones and the dangerous patients. We too have patients with residual pH after surgery, whether they've had recurrent thrombus or not, and there's certainly a role for drug therapy after surgery to treat the microcirculation. Lung transplantation itself, we very rarely do for CTEPH now, and certainly I think in the last 20 years I can only remember 2 patients having lung transplantation after pulmonary endarterectomy, and they are extremely complex operations because there are a lot of adhesions between the lung and the intercostal and systemic circulation. So technically, it's often a relative contraindication. So lung transplantation now is kind of almost removed from the guidelines for treating CTEPH because the interventional therapies are so good and because there are drug therapies and because the technical challenges with lung transplantation in this patient group are so great that the operative risk is very high. So in most cases now, no one would go to lung transplantation for CTEPH.
Great. Go ahead, Doctor.
Yes. So I hope it's not a redundancy to what Dr. Abdullah Dalhan said, but textbook education taught us simply that endarterectomy is a curative for CTEPH and you cure the patient. But we understand that there is a process of small vessel disease, and maybe some subset of patients will end up behaving like a group 1 maybe after they. Is there a subset of those that end up not fully? So we have to differentiate, take away those who with recurrence. We're not talking about recurrence, we're talking about those who remained with a high pulmonary artery pressure even after endarterectomy due to changes of their small vasculature. So what is your advice for clinicians to follow up those patients and when to consider them that they are maybe cured from the thrombosis, but they still suffer the burden of high pulmonary vascular resistance and need oral therapy lifelong? Thank you.
Sure. I think probably I already answered part of it and ask Dr. David to answer basically the other part. I think if you look at the likelihood for having persistent pulmonary hypertension basically after the surgery, it actually varies from center to center. If you look at basically data reported from really different centers, it goes from things like 6% up to 30, 40% if you follow those patients long time enough. So definitely there is some variation between centers about how likelihood that those patients will have really developed persistent disease. And I think we can have some estimate before surgery looking at basically the PVR before surgery. Of course, the higher the PVR, the more likely that those patients having basically disease at the microcirculation. You can look at that really occlusive basically wave from the basic obstructive right heart cath RV basically wave, and you can really say that there is upstream here high resistance. Those patients are likely to have persistent pulmonary hypertension after the surgery. So we do have some really feeling who will and who will not get really residual disease. So, and of course, most of the time, whenever you have patients who have PVR in their thousands, basically, we kind of tell them that it's very likely that you'll have really persistent disease and you will need to have basically lifelong medication after that. Having said that, if you have somebody who have, let's say, the PVR of basically 18, and after surgery dropped to 5, there is no medication can do that. So those patients feel significantly better after the surgery, and then the medication will continue basically the journey. As a matter of fact, I would like to ask Dr. David, because there was one publication came from Japan looking at basically single center. And what they were doing before going for surgery, they do angiogram and try to look for the collaterals. And they claimed in that single center experience, maybe this is, again, quote Abdullah question regarding those patients with real market circulation. And they claimed that if you can detect those collaterals and occlude those, basically embolize them, although to me that could be dangerous because those collaterals would really supply the really obstructed vessels. But anyhow, they claimed that if you really occlude those collaterals, the really post-surgical complication, including basically reperfusion pulmonary edema, the likelihood of having persistent pulmonary hypertension is significantly less. So this is one center experience. I'm not sure, do you do that in your centers? Because when we read that paper, we felt there's something wrong. You should not, maybe you should do that after the surgery, but not before the surgery. So I'm not sure.
I agree. I'm unsure of the biology of that approach. It's a small series, but to me, it's a recipe for lung infarcts. And so I can't quite understand that approach. But I would agree with what you say and what the questioner said, that it depends the degree of residual pulmonary hypertension. This is not talking about residual clot or recurrent thromboembolism, but the degree of residual pulmonary hypertension is dependent on the patient population, how high the PVR was before surgery, how distal the disease is, and how thorough each center is of evaluating patients after surgery. So in the UK, we have a program where all patients have full evaluation 3 to 6 months following surgery, independent of symptoms. They routinely have a repeat right heart catheter at 3 to 6 months after surgery. So if you have that strategy, you will find as much as there really is. But it's important to do that because we now have alternative therapies available. So what we go on and what our evidence on long-term survival has shown, that if following surgery the mean PA pressure is more than 30 millimeters of mercury and patients still have class 3 symptoms, then those patients will benefit from additional therapy and start of vasodilator therapy following surgery, as long as all the obstructive material has been removed. And so that's the group where we're targeting the microcirculation. And many of those patients will improve with vasodilator therapy at that stage where the obstructive disease has all been removed. We also have a small program of BPA for patients with some residual lesions after surgery. And as well as looking at the hemodynamics, we repeat all the imaging 3 to 6 months after surgery. And if patients do have symptoms and there are some small webs or distal obstructions that we may have missed with surgery, there is the option of BPA following surgery as a second-line interventional treatment. I'm pleased to report that the number of patients needing that is very small, and even our experienced BPA operators find those patients are very difficult to improve further, which is a good thing for surgery, but we do attempt that, and we can get small incremental improvements with BPA after surgery.
Thank you very much. We conclude the session as we have to catch up with the prayer, and then we catch up with the lunch, and then we come back to the next session. Any further question could be addressed to the speaker after this session, and announcement from Mr. Al-Urani.
Thank you, chairs, and thank you, speakers of this session. Thank you very much for a great job. Now, our lunch, as usual, just behind this wall, and it's ready now. We'll just open the door. And then we will resume at 2. It says in the program 1:45, but it's 2 exactly. We'll be back here for a very interesting session. Thank you very much. We will take a group picture. Please move forward. The people in the back. Group picture. This is important for documentation. Thank you.
السلام عليكم. بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. Shall we start, please? So this is the last session, I believe, in our successful 2022 meeting for Saph, and it's basically concentrating on local experience in different parts of the world. We have so far more than 1,000 attendee or viewer at virtually, and we're going to start by a report from PVRI, from the Chief Executive Director, Mrs. Stephanie Barwich. And it will be live streaming.
Of our plans, now with you, 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 now. It is. Hypertension. Members throughout the world, and I just want and to have a look at change. Publisher, for more activity. It's flourished. An academic and by a pharma representative, and they target specifically these kind of topics. We want to bring out position statements, white papers, policy documents to enable better drug development and, of course, better access to care for patients. What do we do in terms of supporting our members? We do issue grants. At the moment, we have a 5-year grant which is given to Justus Liebig University in Germany to develop a PVRI Go Deep. This is a registry, a deep phenotyping registry which unites existing registries under its banner for better research, for better phenotyping, and really to help everyone around the world have access to better research data. And I would encourage anyone who has already got a registry to get in touch with us, because we can connect you with the team at Gießen to see if your registry can feature in this bigger registry. You would not lose your data. You would always be the owner of your data, but you would have access to so much other people's data as well. In terms of another project we are doing, we are funding a research project which is to do around CRISPR technology. This is also going ahead in Germany. It is sponsored by another charity called the Dinosaur Trust, who we work very closely with, and it goes over 3 years. We are also embarking on another research grant, which is looking at yoga in pulmonary hypertension as an alternative treatment alongside traditional medicines and drugs. But it features, it's multi-center studies all around India, and it looks again at why yoga can be complementary or can be useful as part of the treatment plan. We also have another family who are high sponsors and good donors. They sponsor the annual Rupert Swift Award. This is an award which goes to a young investigator who is not yet at the fully employed PI status, and this grant enables them to step up to this. So we always encourage applications for that. We have the annual Boutros Young Investigator Award, which is sponsored by Goswam Boutros, one of our founders, and that is awarded to a young investigator for the best abstract at our annual Congress. And we also issue travel grants and fellowship grants. So for our annual Congress in Athens, we have 15 grants which will go to young doctors from all over the world. So please do submit an abstract, and you can perhaps, or hopefully, benefit from one of these grants. In terms of global health providers, we are working at the moment with the Institute for Health Metrics and Evaluation, which is the authorized body from the World Health Organization to undertake the global burden of disease study. We work with them to get a better understanding of how big the burden is of this disease. I've mentioned the Go Deep database that is kind of along the same lines of trying to understand the prevalence of the disease around the world better. And of course, all of this data will be presented at our joint symposium, which will hopefully go ahead in 2023 with the World Health Organization. We are involved in effective advocacy to change the perception that pulmonary hypertension is rare. We want to encourage that there's better drug availability, better licensing of drugs, better general health care for everyone around the world. And of course, that means that we have to change the perception that PH is a rare disease. And partners such as the World Heart Federation, the Pulmonary Hypertension Association in the USA, who are very, very strong collaborators with us, will help us with this endeavor. And of course, I've mentioned launch of PVRI India, which is an exciting new development. So that's it from me. I was told, be very strict. We only have 15 minutes. We have a big program, and I hope I didn't overrun. But please do ask me any questions. And I very much hope that you will join us in Athens. I'm very sorry I can't be there with you right now. But thank you to the organizers. Thank you to everyone for making Saph happen and for organizing such wonderful meetings and such great educational activities around the Eastern Mediterranean region and area. Thank you.
So, because we're going to lose a stream soon, any questions? So the website for the PVRI, I think everybody should check it, because personally I learned so many, I viewed so many lectures out of them actually. So it's full of excellent educational material. So.
Yeah.
So I'm just asking, I'm just introducing or mentioning that the website for PVRI is an extremely important educational website, and I think everybody should have a look at it, and I encourage everyone to go and see what's available, because it's extremely very helpful website actually. So thank you very much. Thank you. I don't know if you can hear me. Okay, so we can. It's muted. Oh, it's muted. Can you unmute, please? Thank you. Yes. Thank you very much. We were just talking about the website, PVRI. And this was a great introduction for some people who doesn't know the PVRI, but most of us obviously know it. And I was asking everyone to check the website, because it's at least, it's full of extremely excellent lectures, and you can see more than, it's 1,000 or something lectures actually. So it's a very helpful website. Thank you very much. Thank you.
A wonderful rest of the conference, and see you all in person very soon. Take care. Thank you for inviting me.
Thank you.
Bye.
Okay. So moving on, we have a slight change in the schedule. So I'm going to introduce Dr. Maria Paz Mateo, because she has a flight. Dr. Maria Paz Mateo is a consultant pulmonary medicine from Philippine Heart Center. And she is the chairman for Philippine College of Chest Physician, Council on Critical Care and Pulmonary Vascular Disease, and the coordinator for Pulmonary Vascular and Pulmonary Hypertension Clinic in Philippines Heart Center. And she will give us a brief summary of the outlook of pulmonary hypertension in Philippines. Thank you.
Good afternoon, everybody. I'm Dr. Maria Paz Mateo. So I'm from the Philippines. Naharak Said. So I'm thanking the society or the Saudi Association for Pulmonary Hypertension, headed by the President, Dr. Abdullah Aladaan, and of course, Mr. Alo Raini, Mr. Hassan, for inviting me as well as bringing me here in your beautiful country. So I'll be talking about the current status of the pulmonary hypertension, the diagnosis and management scenario in the Philippines. Okay. So these are my disclosures. So for my talk, I have an outline for the 4 parts. We have journey to the pulmonary hypertension awareness in the Philippines, the beginnings and challenges, the Filipino patients, the PH registry, the diagnostics and management. Now, as you all know, our country, the Philippines, is situated in the Western Pacific Ocean, and it consists of 7,640 islands that are broadly categorized under the 3 main geographical divisions from the north to the south. So we have your Luzon, Visayas, and Mindanao. Now it has an area of 300 kilometers squared, and as of 2020, we have a lot of population. We have 109 million Filipinos, so making it the world's 12th most populous country. Now, this is my hospital, the Veterans Memorial Medical Center, where I work, and also the Philippine Heart Center. So the Philippine Heart Center, as you see, there is a heart situated at the middle of the map. So it's situated at the East Avenue, Diliman, Quezon City, Philippines. Now this is my first part, the journey to PH or the awareness in the Philippines, the beginnings and challenges. Now, I'd just like to thank our mentors, Dr. Teresita de Guia, and of course, Dr. Ivan Villaspin, for making me what I am today. So, it was in 2005 when I had my fellowship training with my mentor, Dr. Richard Chanik, at the University of California, San Diego, Thornton Hospital, La Jolla, San Diego, USA. Now, at first, the cardiologists in our hospital had resistance on the new subspecialty in pulmonary vascular medicine because I know for a fact that most of the cardiologists look into the left heart. So the pulmonologist goes into the right heart. So we invited Dr. Richard Chanik to our hospital in 2008, and we requested for a lecture as well as a lecture in Philippine Heart Center and our society, Philippine College of Chest Physicians annual convention. So we were able to discuss a case. So it was after then, we had an inauguration now of the Philippine Heart Center, Center for Pulmonary Vascular Disorders, the Pulmonary Hypertension Clinic at our outpatient. So we have my 2 mentors here. So it was after a year then that the college was able to made the month February, so this month, also the Pulmonary Vascular Disorder Awareness Month in the Philippines. So I'm thankful that I was here this month. Okay. So these are my fellows at Philippine Heart Center. And during this period, we do a lot of things like a week-long display of posters and lay fora on venous thromboembolism as well as pulmonary hypertension. Now here, during this pandemic, we were able to again do some display of posters as well as lay fora among our patients. So there's social distancing. And of course, during the time when there was a pulmonary hypertension summit in 2010 in Bangkok, Thailand, we were able to discuss some plans for pulmonary hypertension back in our country with my mentor, Dr. Villaspin. So we were able to participate in the 2013 as well as the 2018 Pulmonary Hypertension World Symposium in Nice, France. So these are the clinical classification we present. So we had a pulmonary hypertension registry in the Philippines, which was made upon the invitation from the World Symposium on Pulmonary Hypertension in 2013 at Nice, France. So although, because it's only a single center, but we were able to produce patients. So we were able to have a collation of all cases, new ones, and previously diagnosed cases. So from referrals from other hospitals. So this included the ones we saw at our Philippine or the pulmonary hypertension clinic since 2009. So these are our forms that we use. But later on, this year, we'll be having a digital website for collation of pulmonary hypertension patients. So these are our objectives for the registry, just to determine the number of Filipino patients with pulmonary hypertension at the Philippine Heart Center, as well as to classify all patients with pulmonary hypertension based on the latest clinical classification of pulmonary hypertension. And we have to know the epidemiology of the pulmonary hypertension among Filipino patients, and to collate now all the diagnostics and results of our patients, as well as the management undertaken. We have to also determine the number of deaths among these patients. So this is the very first in the Philippines. So we have, from the start, so 2009, we have 266 patients. That includes adult and pediatric patients. So the only thing is that we have to enter only those cases who have undergone right heart catheterization. So that would be 104 of the 266. So most of our cases are in class 1, so PAH patients. And you'll see here, we have a combination of your PAH, so idiopathic, as well as your congenital heart diseases. So we have also cases for class 2, 3, 4, and 5. At that time, we have used the Dana Point classification because that was 2009. So there's no much difference in the demographic data. The only thing is that we have patients who has dyspnea as symptoms as well as easy fatigability. So others, patient comes in with tachycardia, with accentuated P2, pedal edema, and RB heave. So as the latest number, so we have about 326 now in NIS 1. So NIS 2 is 158. So followed by NIS 3, 100, NIS 4 is 23, and NIS 5 is 8. So for a pediatric, most of them are on NIS 1. So what are the conclusions here? That pulmonary hypertension also exists among Filipinos. So the data collected will help us to better understanding of the condition among our countrymen. So this data will be updated, and there is an ongoing development of the website. So we have continually participating in the different researches among Filipino pulmonary hypertension patients. So as a co-investigator for cases on pulmonary vascular, so we have participated also in the surveillance, post-marketing of your bosentan, also for your macitentan, and also for the treprostinil study is ongoing, as well as the selexipag study. For the diagnostics, so as you all know, these were adopted in the ERS, ACCP, ECC, and ACC guidelines. So we have the 4 approaches in the diagnosis of your pulmonary hypertension. So we base this on this one. How do we diagnose? So this is just the imaging workup that we follow. And of course, when we went to Nice, France this 2018, before the print pandemic, we were able to make a diagnostic categorization for pulmonary hypertension among the Filipino medical doctors. So from the suspicion, the detection, and some of the classification and identification for primary medical doctors, so your internists, your pulmonologists, your cardiologists, rheumatologists, and your pediatrician. So after which, we, of course, there should be a referral now to your pulmonary vascular specialist. So this is just what we do. So we do some outpatient diagnostics as well with regards to your ILOPROS vasoreactivity testing, as well as your 6-minute walk test and others. So these are the diagnostic tests that we do, that we see. You see this, we have your chest x-ray, your ECG, your 2D echo, your room air oxygen, as well as your spirometry. So these are the findings that we saw on our patients before. So for the 6-minute walk test, you'll see that most of our patients are in functional class 3 when we see these patients, okay? And at the same time, for your hemodynamic data, we saw that most of our patients in the classification 1 are the ones with higher mean pulmonary artery pressure, as well as the PVR, okay? So we also make use of the risk stratification of PH patients. And by management, we follow this. We tell the patients to avoid pregnancy. We give vaccines. We give support psychologically, and supervise exercise training, as well as avoidance of excessive physical activity. And at the same time, we do in-flight oxygen therapy for those patients with less than 60 millimeters mercury, or your classification 3 and 4. And of course, avoidance of your general anesthesia. So we also make use of this one, the use of diuretics for right ventricular failure and fluid overload. And we give oxygen therapy for our patients, as well as oral anticoagulants, especially for our idiopathic pulmonary arterial hypertension and heritable PAH. And at the same time, we make sure that an INR is between 1.5 to 2.5. So we correct the anemia or the iron deficiency. And you see here, most of these drugs, what you see, they are ACE, ARBs, beta blockers, and ibabradine is not recommended unless there is a compelling indication. And we have a foundation at the Philippine Heart Center, which is the Philippine Foundation for Lung Health Research and Development. So we have a whole, we buy medications, bosentan, sildenafil, prostacyclin analog, your iloprost, in order that the patients could buy to us, because most of our medications back in the Philippines, they buy it out of pocket. So these are just the medical management, no? Okay, and the drugs that we use, no, in our country. So in 2011, we had an opportunity to have pulmonary endarterectomy with excision of your pulmonary artery sarcoma. So with that, just like to the disposition of our patients, no? So we would like to trace now those living patients, no? So we have already dead patients with regards to the registry. So with that, maraming salamat po for the opportunity to share to you our pulmonary hypertension awareness in the Philippines. Thank you po.
Thank you very much for staying in time, actually. So yes, thank you. So moving on to Dr. Ashari bin Yunus. Dr. Ashari is a consultant pulmonary medicine, National Heart Institute, and he's a chairman of Malaysian Clinical Practice Guidelines on Management of Pulmonary Arterial Hypertension, Kuala Lumpur, Malaysia. Dr. bin Yunus.
Assalamualaikum and good afternoon. Thank you, Mr. Chairman. I would like to thank the organizing committee who invited me to talk on this topic, the current status of pulmonary management in Malaysia. So I'm the pulmonologist from Institut Jatinegara or National Heart Institute, Kuala Lumpur. I have nothing to declare. So you can see the map of Malaysia. The map of Malaysia, there's population Malaysia about 33 million people, and mainly in the capital of Kuala Lumpur, about 8 million people. And the health facility in Malaysia, mainly in the hospital, we divide into three parts. One is public hospital, belong to government hospital, and the university hospital, and also the private hospital. The few hospitals managing of primary hypertension, only 3 hospitals. So the main referral for primary hypertension in Malaysia is at National Heart Institute, and the PH program in Malaysia started in 2003 at our institute. We started with the IPH, and then we moved forward. In 2008, we have IPH and the congenital heart disease. And by 2019, we have full service of primary hypertension, including the group 1, mainly the IPH, congenital heart disease, chronic disease, and the group 2, mainly managed by the heart failure team. And the group 3, we manage with COPD, insulin disease, and OSA. And group 4 as well, we manage CTAP, and the group 5, we have rarely received the referral. So IGN is the main referral center for primary hypertension in Malaysia, and we work closely with the heart failure team in IGN and also heart lung transplant team in IGN. So this primary hypertension database report in September 2020. So if you look here, the type primary hypertension, we have the group 1, majority about 96%, and followed by the group 4, and also the group 2. Group 2 is, we have many patients of the heart failure, but managing by the heart failure teams. So from group 1, they further divide. We have the mainly congenital heart disease, about 65%, and followed by the idiopathic primary hypertension, about 24%, and then the connective disease, about 10%, and the heritable, about 0.2, then HIV is less, then primary hypertension, portal hypertension, about 3, about 5.5%. So you look at medications on the last follow-up in 2020. You look at, we give the calcium channel blocker, oral anticoagulants, and also diuretic to the patient. And for pH targeted therapy, we give to the patient the single therapy, monotherapy, and double therapy, and also triple therapy. So if you look at about 644 patients we have, it's not shown here. And it looked like about the no-specific drug, about 97 patients, and followed by the dual therapy, about 40%. Then the single therapy, about 30%, then triple therapy. So we have the list of the drug we have in Malaysia, including all type of the drugs, except few drug we don't have. So in terms of mortality is a majority of patients die outside of our center. So we don't know the cause of why patient died. And about 80% still alive. And if you look at the public service in Malaysia, we have the manpower, we have the cardiologists, we have the adult and pediatric cardiologists, we have 2 adult cardiologists, and we have 2 pediatric cardiologists, we have pulmonologists, we had the CT surgeon, we had 2 surgeons in our team, and we had facilities, we have echo, we have CAT lab, primary function test, sleep lab, and imaging center. So in June 2011, we have our own guidelines. They aim to not to comparing the established guideline, but to educate our doctors and also to get support from the Ministry of Health, to get financial support, to get a budget from them. So it's very difficult to convince the government to give free medicine to our patients. So we have to make the guideline. So if you look at the primary hypertension targeted drug, so if you compare the standard in Malaysia, we have almost all the drugs. So we have ambrisentan, we have bosentan, original and generic, and we have macitentan for the endothelin receptor antagonist. And for phosphodiesterase type 5 inhibitors and subegalinate, we have the sildenafil, original and generic. We have tadalafil, and we have riosigod. For the prostacyclin analog, prostacyclin receptor agonist, we have inhaled elaprost, we have beroprost, which probably not used in the Western country, and we have selexipag, and we in process to get in pipeline to intravenous epoprostenol, and also we have need the inhaled prostenol for our patients. So as tertiary center, we receive a referral from the government hospital and university hospital and also private hospital. Who supported our patients? One is, of course, the government, but the government gave only generic drugs, majority of our patients. And from the Heart Foundation, again, supporting the group, and we get from employer, it will be a big company, and also we have religious body to give our budget sometimes, Muslim religious body we call zakat. And so from insurance and also the cash paying patient who does has rich patients. So for the group 1 primary hypertension, mainly is idiopathic primary hypertension and familial hypertension, congenital heart disease and connective disease, including the scleroderma, main connective disease, and also SLE. And what we do, we ask, as usual, as clinical review of the patient. We suspected patient primary hypertension. Then we proceed to appropriate investigation, and including the right heart catheterization. And diagnosis, when the diagnosis is confirmed, we start with the monotherapy. We start monotherapy first, and we follow by, we usually start with the sildenafil or tadalafil. The dose of the sildenafil, we give the 20 milligram TDS with Yabaso or 25 milligram TDS Viagra, and increase to the after we review the patients. And also we give diuretic, dioxin, and anticoagulant. We not, when we review patient, we give the subsequent combination. It's not the upfront combination because we know that may increase the cost to the patients. So every patient, PH patient, receive a PH passport, we call, for monitoring, and we assess the risk of this risk of the patient every visit. So the risk assessment, we follow the standard risk assessment, and we don't do hemodynamic regularly because it's too expensive to us to do every time patient come to the visit to our center. So usually we review patients every 3 monthly, if patient is stable, and we might increase the dose of sildenafil up to 50 milligram TDS. And the combination drug, we use as I mentioned, is the sequencing combination. And we do not use the upfront combination because it's too expensive. I know that upfront combination is very good compared to this sequencing combination in treatment of pulmonary hypertension. For sequential combination, we start with the PDI-5 and ERA, and this sildenafil, tadalafil, bosentan, or plus macitentan. And if patients does not improve, we started with the prostacyclin analog. We give alloprost to our patients. When do we refer for transplant? We have transplant program in Malaysia. We refer early to heart-lung transplant team for transplant assessment. Usually the heart transplant team are the same as the primary team. So who does sit in the primary team is transplant team. And if patient indicate clinical response on maximum therapy, we thinking that we need to give the epoprostenol to our patient. And this epoprostenol is our program in pipeline. We don't have yet for intravenous epoprostenol. And we don't do the balloon atrial septostomy to our patients. So this the diagram to show that how we do how we manage treat patients, our PH patients. So we don't have the BAS. So we go straight. If patient not improve with the sequential combination, we go patient for lung transplant. If we put patient in the waiting list. So we have the association, we call the Persatuan Pulmonary Hypertension Malaysia or Pulmonary Hypertension Advocacy Malaysia. This belong to the patients, and patients come and discuss about their problem and tell us. For the group for pulmonary hypertension, the diagnosis will be based on the CTPA and BQ scan. We're exploring now to the dual energy CT lung function imaging. And we really do the right heart catheterization for the CTAP. Our experience, CTAP developed from acute pulmonary embolism, DVT, and age group, the elder age group between 50 to 70 years old. And this, I have known about this, and then we had the level, had management of getting the level 1, level 2, level 3, and level 4. And what we do, we start patient with diuretics and anticoagulant, warfarin, or xylitol, and we give oxygen to the patient. And we have program for the PEA. So we have experienced about 10 cases and about 20 patients mortality. And we don't have the BPA, so in the pipeline we have to learn the BPA. And some of our patients for the receive the Reseguard and macitentan. For the group 3 hypertension, which our experience in case of insulin disease, mainly IPF, and COPD and sleep apnea. We treat the underlying problem. We move from BQ scan now to the CT scan perfusion imaging, and we don't have experience with the inhaled treprostinil. So we need to do that, coming into this drug to our center. So in summary, we are aware that standard guideline treatment of primary hypertension, we need to modify the treatment according to the financial support and the budget. And we are in the process to enhance primary management by looking forward to BPA, intravenous treprostinil, nebulized treprostinil, and dual energy CT scan, dual energy CT lung perfusion imaging. We'd like to collaborate with the international community of hypertension in research to treat this challenging and expensive disease. I think that's all my talk. Thank you.
Thank you very much. For the time's sake, we're moving to the next lecture. So we're moving to Ukraine, the state of pulmonary hypertension treatment and management in Ukraine by Professor Yuri Sirenko, who is a professor and head of Department of National Scientific Center at Strazisco Institute of Cardiology, and he's a senior advisor of Ukraine Ministry of Public Health and the head of Pulmonary Arterial Hypertension Center.
Dear Chairman, dear colleagues, first of all, I would like to express thanks to the organizing committee again for inviting me and personally to Dr. Abdullah Abdullah for this very nice hospitality that we have here. So I would like to start also from the map. I'm sure that the people who never heard of Ukraine before last month are aware about my country and bad political games around it, even much more than myself. I also thank all of you for support. This morning I received the letter of support from Stephanie Barvik. You heard talk today, and really thank you very much for support, and I hope everything will be okay. So we have a population around 40 million and enough square comparable with France, as you understand. Capital city is Kiev, and currently we have only one reference center for adult in our Institute of Cardiology and one center for children in Children's Hospital. We have, we thought, we have 3 auxiliary centers in 3 huge cities: city of Lviv, city of Kharkiv, and city in Dnipro, all are cities with a million population. That's why we have to collaborate with them. The goals of our center is providing modern management to patients with pulmonary hypertension group 1 and group 4. Selection patient for intervention, surgical treatment, education, medical staff, participation and creation and review of national guidelines and standards. I have to say we developed our national guidelines based on the European guidelines 2015 and follow them as we can, and I guess it's a rule number 1 when we started. Okay, and we have good links with patients' organization, and we provide the conferences and studies. Here is dynamic of follow-up our patient. We started in the year 2014, only 8 years old, and our result this year our celebration of our 80th anniversary will be in the end of May, and you can see how growing numbers of our patients, and when started the national program for free drug support for those patients. You can see how dramatically increased numbers of patients that we follow up. You can see here we have followed up 540 patients, and 92 patients died, so we have 240 alive patients for our follow-up now. Here is the structure of patients in the reference centers. I would like to compare with two registers, French and Reveal register. I try to use the same colors, and you can see the majority of patients in those registers, around 40–45% were patients with group 1. When we compare it to Ukraine with idiopathic pulmonary hypertension, when we compare to Ukraine, we have only 20% of patients with idiopathic pulmonary hypertension and 42% patients with congenital heart disease, in comparison to 11% in French and American registers. I guess it's a bad legacy of the absence of pediatric surgery of the first year life. Also, we have small numbers, only 6% connective tissue disease in comparison with the French and American register, from 15 to the 20%. It's a problem, I guess, with cooperation with our rheumatologists, because they are not aware about a dangerous situation concerning the pulmonary hypertension in those patients. So here is our main patients group characteristics. Idiopathic pulmonary hypertension, more than 100 patients, average age 43, 84% female, and death rate for 8 years is 22%. Connective tissue disease, 35%, more older, 53 years old, 88% share of female, and 26% died. Congenital heart disease, more than 200 patients. The average age, 37 years. You can imagine how long those patients can live. 2 years ago, one patient, one female patient, 77 years old, come to me with a congenital heart disease, atrial defect, and she said, "Okay, I have a dyspnea. What I have to do?" I said, "Okay, what the cardiosurgeon told you?" 25 years old, they told me they have to die, but all them die. I'm survived. You understand what I mean? But it's really very severe group of patients, and especially severe for treatment. The death rate was 11% only, but I show you how it changed. CTF patient, 100 patient, also older, 53 years old. In this group, 50-50, female, male. Share, and 26% only operated, died 23%. Here is our own data. I have to say only from our center, because we did everything for those patients, including our own one-center register, because we don't have any support from the government in this field. So you can see here right heart catheterization performed in our center, around from 50 to 60 procedures every year, around 20 vasoreactive tests, new vasoreactive tests. And in the years before, we didn't repeat catheterization because economic problem. Now we try to repeat in the cases where we need to confirm vasoreactivity or confirm worsening of situation only. In cooperation with Heidelberg University, we perform 5 genetic tests for our patient in suspicion of family form of idiopathic pulmonary hypertension. In 3 cases, we confirm the genetic disorders, and also we perform 2 analyses for the family members of those patients with the negative results, thanks to our colleagues from Germany. Structure of the therapy. I didn't separate patients first and fourth group because we have to give them almost the same therapy. Our national program, just only 1 year, tried to supply with a real Sigwart, and then, because the high price of this drug excluded it from the national program. Okay, you can see majority of our patients, 60%, receive dual therapy, triple therapy only 10%, and monotherapy 21%. And 8% refused from the therapy. Majority of those patients are patients with a functional class 1 and congenital heart disease. Here is the reveal data about mortality, and I just would like to remind the worst prognosis in patients with connective tissue disease. We did the same publication and where the same data, the 4-year survival of those patients in our country was 50%. And we were aware that everything is okay. After that, started COVID pandemic. 1 year ago, we published our data about pandemic. We traced 373 patients from the beginning of pandemic till the starting of vaccination. You understand? It's a clear data because vaccination really changed this disease profile. So 71 patient, it's not so much, 90% of all cases were infected, 17 need to admission to hospital, 6 admission to intensive care unit, respiratory support, and unfortunately all of them died. And we decided that everything is not bad because this is not severe influence of this pandemic of the survival of our patient. However, situation changed 1 year after the last year. And you can see here the worst survival of patient is CTEPH and connective tissue disease. However, you can see how patient with congenital disease dramatically increased mortality during the last year. I guess it's also connected with COVID influence on survival of those groups. About our cooperation, we started our cooperation with PVRI since 2018. You can see here our British colleagues, our Poland colleagues. You can see Dr. Adalan in our conference center. Our conference center situated with the major Olympic stadium in Kyiv. That's why everyone wants to take picture looking at the stadium. Here is also a picture of our British colleagues, British and Polish colleagues here. And naturally, we have challenges: diagnostic, treatment, and scientific studies. Diagnostic challenges concerning that there is a rare disease, not all remember about this, and not much time for studying in university. That's mean late diagnostic for all majority of our patients. Also, majority of our patients come to us with a third functional class, like registered you already shown. Often diagnosis is based only on the echo. That's the main hyperdiagnostic. No understanding CTF pathogenesis. That's why we have just one center. Nowhere we can provide VQ lung scan, unfortunately. We just started cardiopulmonary test, and we started genetic tests thanks to our German colleagues. And there is no effective control of physician follow-up to standard of care. Concerning physician education, the majority of them do not know well indication for specific therapy. Hyperadministrated calcium channel blocker, and patient with CTF consider it as a fatal patients. So our national program started just from few drugs, sildenafil and iloprost. Further, they joined for short period rosiglitazone. Currently, we have bosentan and, thanks God, abrisentan, however, just for small numbers of patients. Scientific challenges, full supply, we participated in 3 or 4, currently participate in 3 or 4 clinical trials. However, we are not sure that our sponsor are aware about our country and about our possibility. Here is our small pulmonary hypertension team, just all those persons rule 500 patients. And I thanks to my colleagues for their collaboration and their support. Thank you very much for your attention.
Thank you very much. Moving on to Kyrgyzstan, actually, pulmonary hypertension treatment and experience in Kyrgyzstan. Prof. Tarantabek Soronbayev, he's from Bishkek, Kyrgyz Republic, and he's the president of Kyrgyz Thoracic Society.
Thank you very much. Dear colleagues, first of all, I would like to express my big thankful for Dr. Aldalan and Hassan for inviting me. This very pleasure and very honor for me. This very nice, wonderful meeting, and a lot of, it was possible, including for me also, to have a lot of knowledge, skills, new friends, and it was very nice to meet our friends from which we have many years good relationship. And in my presentation, my talking will be briefly about our region, our country, our region. I will be very glad to share with you our progress for management of PH challenges and futures, what we can do together and what we can do, and about our thinking for progress management of PH in our country, in our region also. In this slide you can see Central Asia region. Kyrgyzstan, one of Central Asian countries. This is not so big country, and we are borders with Kazakhstan, Uzbekistan, Tajikistan, and also very close for us Turkmenistan. This is all Turkish speaking. We call Turkish speaking countries, but mainly more than 90%. In our region, this is main religion is Muslim. About 60 million population, let's say very big population in this region, and very different climates, different and unique natures. In this slide, you can see Kyrgyzstan. This is country just with mountains, a lot of mountains. And usually people stay in very beautiful valley between mountains. And as you can see, we have some very big plateau where stay people is altitude more than 3,000 meters above sea level. And very important point that more than 94% of territory our republic covered by, occupied by mountains, and more than over 50% of settlements populated by 1.75 million people located at the altitude of 2,000 meters or more. And very important, that is why very important for us, health of people who living in high altitude regions. We have, as I already mentioned, a lot of very big population, around 200,000 adult population live in high altitude area, and one of high priority topic for us, high altitude pulmonary hypertension. As you can see in this slide, we have high altitude pulmonary hypertension severe cases in 4–6% of Highlanders. And we have another studies from other high altitude plateaus, and you can see we have, for example, by ACG criteria, we have, for example, right ventricular hypertrophy, more than half of the patients, 52.2%. It means this is very serious problem for our countries. Unfortunately, we don't have any data about mortality rates for pulmonary vascular diseases, including high-altitude pulmonary hypertension. This is one of our priority topic for research in future, what we have for this, currently for this moment. And I would like also to share with you some our information about our activities and progress in Kyrgyzstan, also in Central Asia. And I would like to note that progress for management of pH in our country was started 2014 when we created Central Asia PVRI Task Force. It was during Congress of PVRI in Gießen, January 2014, and you can see in this slide photos of two our colleagues, Professor Academician Aldashev and Professor Mirahimov. It was very important to unite all our activity in Central Asia for improving situation with management of pH. And main focus was our mission was education, research, improving diagnosis and treatment of pH, quality of life, and finally reduce mortality. You can see in this slide, we developed and we discussed and we approved our action plans for 5 years about creation PVRI expert centers, about importance to develop clinical guidelines, about PVRI master classes, educational schools for physicians, training, support of young researchers, public awareness, and also about developing a simple register system for register of pH patients. And very important for us, very important was same year we started our collaboration with Saph. As you can see in this slide, Central Asia region and Saudi Arabia and some Arabic countries. Our priority point to continue and to have long-term effective cooperation with Saph. We call our Central Asia pH Association Saph. I think, I believe we will have very good and productive collaboration in future. And it was first our event from our collaboration, PVRI and Saph Masterclass, which was organized 2015 in Bishkek. You can see here in these pictures, you can see Professor Stefano Gio from Italy and Professor Tarek Kashur, who was represented Saudi Arabia Saph. And also we invited some colleagues from Russia, and you can see also in these pictures Professor Ghazvan Boutros, who is one of co-chair Central Asia PVRI task force. In these photos, you can see very important master classes from Tarek Kashur about catheterization, right heart catheterization. This is our laboratory in our center, and also very nice pictures where our colleagues from Kazakhstan, from Uzbekistan, from Kyrgyzstan, and Professor Stefano, he explained some very important measurements approach for pulmonary hemodynamics. So it was from our collaboration with Saph and PVRI, it was very important that we created PH expert centers in Bishkek, in Kyrgyzstan, and also in Almaty and in Astana, Kazakhstan. It was supported from PVRI, and I am very glad to say from Saph, and coordinators was Professor Ghazvan Boutros and also Professor Majdi Idris. And we developed and published already in this year, 2016, it was in Kyrgyzstan and Kazakhstan, our national guidelines for pH, and also for this moment, currently we have our plan about active work in Uzbekistan, in Tajikistan, and Mongolia. This is very brief information about our expert centers. In Kyrgyzstan, now we can have 2 centers where we can do right heart catheterization, and several centers where available echocardiography, and also CT scan, pro-BNP, unfortunately not available for many centers, but for expert centers this is available. Unfortunately, we cannot do staff. We cannot have full management for patients with staff, but this is also in our plan. But in Kazakhstan, they have a national cardiosurgery center where they can do also end arteriectomy and some other treatment approach for patients with staff. It was also so nice. We had every year some important events before COVID-19 pandemic. It was very nice. Our first meeting, CAF-SAF meeting 2016 in Issyk. This is high altitude lake in our country. You can see some pictures, beautiful places. This lake located about 2,000 meters above sea level, just mountains and a very big lake with very nice nature around. It was also a very productive meeting, and it would be nice if we will continue like this collaboration between CAF and Saph in future. I believe it will be possible. We started our simple register, which includes registration of patients with all types of pH and different functional classes. And also, it was very important, we established patients' organization in Kyrgyzstan. You can see first meeting with PH patients and their parents. It was 2015. And this, our patients' organization, still working, but unfortunately, I cannot say very well working, but very important that we already started give focus for these important points about involving patients and parents also for helping PH patients. What about challenges? Gaps in knowledge of doctors about pH, poor awareness of population about pH. We don't have special educational program, unfortunately, in the government level and in the different our institutes. We don't have enough trained doctors for PH. That is why this is also one of priority topics for futures. We don't have enough PH expert centers in Kyrgyzstan and Central Asia, especially in Central Asia. And problem, very special problem, this is availability of special medicines for management of PH. And inadequate access to modern methods of diagnostics, right heart catheterization, not possible, not available, unfortunately, in many places in Kyrgyzstan and in our Central Asia region. This is one of priority topics for futures. What about new horizons and what about perspectives for CAF and Saph collaboration in future? We discussed already as today, would be nice to organize CAF master classes in Kyrgyzstan and Central Asia, which will be supported by experts and speakers from Saph. Annual Saph-CAF meeting or sessions, if possible, we can discuss about it. Saph-CAF teleconference every 6 months to discuss clinical cases. Also, I think one of important point. Organization and include the CAF session in the program for annual Saph meeting for demonstration of clinical cases and other futures for the management of PH in the Central Asia. Organization, this is just for, just ideas about organization joint Saph-CAF session at the annual PVRI meeting. And would be nice if Saph can support organized training for echo and right heart catheterization in the leading centers of Saudi Arabia for doctors from Central Asian countries from CAF. And of course, it would be nice also to have joint research activity in the future. And as I already mentioned, for us priority research topic, this is high altitude pulmonary hypertension. And I would like just to show you very briefly also about our HAPH registry, which we have from 2012. And this year we will have already 10 years results from 10 years observation for cohort of 150 patients, cohort patients with high altitude pulmonary hypertension. This is just in some pictures, one sections of our HAPH registry, some data. This is our high altitude station, research station, where we have this work with our HAPH registry. You can see we have very good close collaboration with Swiss colleagues. This is our high altitude yurt research station. Usually in summertime we build it several yurts, and each yurt, this is like laboratory. Inside we have devices and everything what needed for research. This is our high altitude Kyrgyz-Swiss high altitude medical research center located 3,200 meters above sea level. We have all conditions and everything what needed for staying, for research, for patients, for researchers. And I would like to show you pictures of my teacher, academician Mirahimov, who was in Soviet Union time, who was leading specialist for PH. And he was head of Soviet Union working group for developing PH program. That is why I would like to show you, because Soviet Union was very big country, but leading specialist was from Kyrgyzstan, and he was my teacher, academician Mirahimov. Thank you very much for your attention.
Thank you very much. Thank you. And thank you for all the speakers actually coming from far away to present their experience and sharing with our center their experience. I would like to ask Dr. Abdalan to come and give us the closing remarks for this conference. Thank you.
Assalamu alaikum. I cannot think of a better concluding session than sharing the experience with our colleagues, their own experience
in their countries, from Kyrgyzstan, Philippines, Malaysia, and from Kiev, Ukraine. So thank you all for coming, and thank you for sharing the experience. As my colleagues promised you yesterday in their meeting, the board, Saph board meeting, we will start some sort of collaboration. The seeds already started with CAF, so we will continue in that. We will build on that, and I hope we will have a contact soon so we can actually reinitiate all these commitments from Saph to our brothers and sisters in the Central Asia and other countries, inshallah ta'ala. So before I conclude and start thanking everybody for this conference, I will have to announce, this is the second announcement for the digital hub that has been recently built for the ownership of Saph, but I'll explain to you how this is going to work. Remember, during the pandemics, there has been a missing link between patients with pulmonary hypertension and the treating physicians obviously because of the pandemic. So there was, in hospital where there was no IT infrastructure, it was very difficult to communicate with patients. In some centers where the IT infrastructure is there, like at King Faisal, for instance, we had a chance to have virtual clinics and remote satellite clinics operation as well as phone clinics. In some centers, when there was no IT infrastructure, this has been difficult. So a company, where's Bayer people, they really, we have discussed this probably a year or two before the starting of pandemic, but when the pandemic came, so expedited the process. So we built this digital hub, which will play a role in connecting patients, doctors, and doctors to doctors, patients to nursing, and nursing to patient as well. It is very simple, very easy application. I'm not going to go through the application because this is our second announcement. The first announcement was in September, and the board members met at that time. They had a few things to be done for the suggestions for the application to be upgraded to. The company worked on it. It is in the final tuning stage now. It basically has a hub for the doctors who are experts in pulmonary hypertension, and all patients will be able to register in this digital hub, as well as all clinical nurse coordinators in different centers. Doctors who are interested to do pulmonary hypertension care from different cities in the kingdom, they can actually also register in this, and they can have direct communication with the experts in pulmonary hypertension. We have about 12 experts who are going to be, the information is going to be built in the system. So any physician who has a patient with pulmonary hypertension who want to have a consultation with a colleague from Jeddah or from Riyadh, he can just send him a message with the medical report, with the CT scan of the patient, our right heart cath, and everything. It will also facilitate the referrals of the patients from different small cities and towns and villages of the kingdom to the main centers in Riyadh or Jeddah, or even the Eastern Province. So Anne is going to be a great help for patient care from aspect of referral, but also from consultation aspect as well. So thanks to Bayer for helping Saph to have this. Of course, once the application is complete, we have to have a legal governance for this, so we can actually own it completely by Saph, and everything else, all the information and the privacy and everything will belong to Saph, and nobody else will have an access to any of the information of the patients or the doctors. So that's about the application. I would like to thank everybody who made this conference a reality. I would like to thank you for staying to the last minute of the conference. Many thanks to my colleagues who came from a different part of the world to participate and share their experience. And many thanks also for the speakers who came all over from Europe to help to enrich the program as well. My colleagues who are the local presenters, the chairs of the different sessions, the enriching questions that we had throughout the last 3 days or so. And obviously, I would like to thank the sponsors who made this conference happening. Without them, it would not have been obviously arranged. Thank you for the audiovisual group who helped us to make it happening. We had some difficulties, but most of these difficulties, by the way, from the other end, not from us. It's also my pleasure to thank those who participated as virtual talks from Europe. It would not have been complete without thanking my dear colleague and friend, the executive administrator of Saph, Mr. Hassan Al-Araini, who had helped this really an world-class organization. He has been very stressful the last 3 days. He wants to make sure everything is done the best way he can, and I think he did. Applause to him. It's my pleasure also to announce the Saph 2023. The board meeting was held this morning, and the decision was made to be done in Al Khobar, Saudi Arabia. It's a city on the side of the Gulf Sea. It's the opposite side from Jeddah, eastern province of Saudi Arabia. And it's going to be on the 16th to 18th of February next year. So from now, I'm inviting all of you to attend Saph 2023. I wish you the best, whoever is staying in Jeddah, to enjoy the rest of the day, and safe journey for those who are leaving Jeddah tonight or tomorrow, especially for our international guests. Thank you so much for coming. And at the end, we'll just say, في أمان الله ومع السلامة.